Good afternoon, everybody. I'm Dr. Pratik Tambe, Chairperson for the AMOG's Endocrinology Committee. A very warm welcome to all of you, respected dignitaries and faculty who assembled for today's event. Today's theme is high risk pregnancy, and we're really privileged to have some fantastic speakers and very eminent senior stalwarts as chairpersons for today's event. Thanks also to the audience who have joined us today throughout the length and breadth of Maharashtra as well as the rest of India. Next slide, please. I'd like to start by offering my gratitude to my president, Dr. Nandita Palchetkar, current president of AMOGS and immediate past president of Foxy. We've had a wonderful journey with President Madam right since she was the time of the president of the Mumbai Society, then in Foxy, and now, of course, in AMOGS. She's always there to support us, encourage us, and promote all her juniors. Thank you very much, ma'am, for always being there for us. Next slide, please. I also need to place on record my gratitude to Dr. Arun Nayak, who's our secretary of AMOGS. Similarly, sir was also the president of Mumbai Society a few years ago. He's always there to promote and disseminate knowledge and help and encourage youngsters whenever we have any academic activities. Next slide, please. Next, we also need to thank our zonal coordinator of AMOGS, Dr. Kedar Ganla, the chairperson of ICOG, Dr. Mandakini Meg, the secretary of ICOG, Dr. Parag Biniwale, for granting us ICOG credit points for all our events, including today's event, which is themed on high risk pregnancy. We have a host of stalwarts as chairpersons for today's program. The first of these is Dr. Rajendra Singh Pardeshi. Sir is currently the Vice President of AMOGS. Last year, he was the Vice President of Foxy. Along with Dr. Nandita Palchetkar, exactly the same team has continued in AMOGS this year. He has the unique distinction of winning the Best Paper Prize at AICUG 6 times, and that is something which is probably an unparalleled record. We really love to have Sir at our events. I think he's a little busy in a surgery, and Sir will join us very soon. Next slide, please. Professor Krishnendu Gupta is a legendary stalwart in the field of OBGYN. Sir is the professor and unit head at Vivekanand Institute of Medical Sciences in Kolkata. He has in the past been the chairperson of the Foxy Endocrinology Committee, and for this we felicitated Sir at AICOG in Lucknow earlier this year. He's also been a vice president of Foxy in the past, and of course, he's been a chairperson of ICOG as well. Several distinctions to his credit. He is now currently the Foxy representative to AOFOG for the duration of 2020 to 2022. We love to have Sir at our events. He's very evidence based and he's very precise in whatever he speaks. It would be wonderful to have his insightful comments at today's event. Next slide, please. Dr. Archana Verma, the dynamo from the north, is the vice president elect of Foxy for next year. She was chairperson for the Public Awareness Committee of Foxy in the past. She's won the Best Committee Award for Foxy. She's been organizing secretary of North Zone Yuva Foxy in 2016, organized several other conferences as well, recognized very widely for all her unique contributions to whichever organization she is part of, including appreciation award from the governor of UP and the CRPF director for the unique series of programs which we did last year to aid the families and the female personnel of CRPF throughout the length and breadth of the country. We really have a wonderful, eminent personality here today in the shape of Dr. Archana Verma. Thank you so much for joining us, ma'am. Next slide, please. Our last and most senior stalwart of AMOGS, who has exhausted probably every single position that the organization can offer him, including the honorary secretary of AMOGS, the zonal coordinator, and currently he is the state coordinator. Dr. Amay Purandare is a friend, philosopher, guide to so many of us who are from the Mumbai Society, not only those of us who are from Mumbai, but also from all over Maharashtra. And I would say probably now he's a national figure as well. Sir was the joint secretary of Foxy last year. He's been the chairperson of the Food, Drug and Medico Surgical Equipment Committee of Foxy, Assistant Administrator at the Foxy Manyata project. And I'm very pleased to announce that Sir will be very soon contesting for the post of Vice President of AMOGS, and we wish him well in his endeavors. As Dr. Archana Verma has said, he not only deserves the Vice President post, but probably in the very near future, he deserves the President post of AMOGS as well. Thank you so
Yes.
much, Dr. Amay Purandare, for being here with us. And to further take us through the proceedings, I will hand over to the chairpersons. I will just make a quick note. We have three eminent stalwarts as speakers today: Dr. Mohan Raut in the field of immunotherapy, Dr. Vatsala Dadwal, who is going to speak to us about fetal anemia and intrauterine transfusion. I heard her talk a couple of months back at another event, and I felt that I could not have had a better speaker in this topic, and I'm really happy to welcome her on the AMOX platform. Dr. Sujata Dalvi, the third speaker, of course, is the Joint Secretary of Foxy, and she's a stalwart of the Mumbai Society in her own right. But to further take us through the proceedings and to introduce our eminent faculty for today, I hand over to the chairpersons to further conduct the proceedings. Dr. Archana Verma to introduce the first speaker, Dr. Mohan Raut, please.
Uh, Thank you.
Amma,
Thank
you
you,
are
Dr.
muted.
Pratik, I would like to thank you for those kind words and Dr. Archana Verma for your blessings. I'm really looking forward for this new journey in AMOX, and I have been associated with AMOX for almost now 3 decades of my life, right from my childhood, and I hope to take it to even greater heights. Thank you for all your good wishes, and thank you for all AMOXians for their everlasting love, support, encouragement, and feedback in improving my AMOX day in and day out. Thank you.
Best wishes to Dr. Amay Purandare, of name which really sparkle the most in this galaxy. And Dr. Pratik Tambe, thank you very much for inviting me. This Dr. Nandita Palshetkar and Amox and Dr. Amay Purandare and Pratik Tambe, this दिस पूरा ये जो वो डायस है ना तीनों लोगों का आई थिंक आई एंड डॉक्टर अरुण नायक नथिंग कैन बी बेटर so really Dr. Mohan Raj is I'm just meeting him for the first time, but I think as Dr. Pratik Tambe said, he is one of the most eminent speaker also, and he is consultant gynecologist and obstetrician and partner in Dr. Raut's Center for Reproductive Immunology, and he is a trustee also there and foundation. And in 1992, Dr. Mohan involved in the International Multicentric Research Program in association with Oxford University on the role of active immunotherapy, which is his topic today. And I think it's a most unusual topic also. And he had been involved in active immunotherapy programs, lit therapy in Mumbai, and he has contributed a chapter also in on immunotherapy in repeated miscarriages in the book Pregnancy at Risk, Current Concept, published by the Foxy. And he has published papers and has spoken in many national and international conferences. And he has written a book also. Welcome, Dr. Mohan Rao.
Thank you, Dr. Archana, for the kind introduction. I'm thankful to Dr. Nandita, Dr. Pratik Tambe, and Amox for giving me this opportunity to speak here on this platform of Amox on the subject of immunotherapy in repeated miscarriages and recurrent implantation failure. And as the topic says, that immunotherapy simplified. So let's see today in next 25 minutes, 25 to 30 minutes, what we can get out of this and to what we can know more about this complex subject of immunology in pregnancy. So I will start sharing my screen. So it's clear, screen is clear?
Okay. Yes, sir.
Yeah, I'll be speaking on the subject of immunotherapy in repeated miscarriages and recurrent implantation failure. I think with high risk pregnancy, maybe I will restrict to recurrent repeated pregnancy loss. And as the name suggests, immunotherapy is simplified. So I will try to go into the details of the why and when and how of immunotherapy in RPL. Before I start, I am thankful to my alma mater, KM Hospital and St. GS Medical College, where I learned the basics of immunology and obstetrics. And of course, our teacher, Dr. Usha Krishna, with whom I was associated with the first research project from Oxford way back in 1991-1992. So what is immunotherapy? Immunotherapy is Immunotherapy, or also known as biological therapy, is the treatment of disease by activating or suppressing the immune system. So the immunotherapy may be used to amplify the immune response, then it is called the activation immunotherapy. And if it is to reduce or suppress the response, then it is suppression immunotherapy. The use of immunotherapy in unexplained repeated miscarriages or recurrent pregnancy loss or recurrent implantation failure is what we are looking at today, and which are considered due to alloimmune dysfunction. So the scope of my talk today will be, do we really require immunotherapy in RPL or RIF, and why? If we require, then in which cases of RPL, RIF immunotherapy will be beneficial? Once we know who will be benefited, how do we give immunotherapy? And lastly, if we have to give immunotherapy, does the recent evidence corroborate it? So we'll see one by one these points, which will cover the topic in entirety. Now, all of you are aware that there are different definitions of repeated pregnancy loss. According to ASRM, there are 2 or more miscarriages, and ASHRAE says 3 or more. But in effect, women affected by repeated miscarriage can vary from 2 to 5% depending on what definition you take. There are different causes of repeated miscarriages. I'm not going into the details, but the fact remains that almost 50 to 60% of couples, all these factors are normal and they are labeled as unexplained repeated miscarriages, and we don't know what to do about them. There is an interesting information which I would like to share here from the Ministry of Statistics and Program Implementation, which states that there are the incidents, the couples with wife in childbearing age group, the number is 170 per thousand. I think I'm going to do going through these numbers to tell you the incidence, actual number of patients who are suffering from miscarriages. So the total number of couples with wife in childbearing age group in India will be 213 million if you consider a population of 1.25 in 2011. That's what the report is dated. So the incidence of RPL, if you take 2%, we have 4.25 million couples with RPL. And if you take 5%, that is 2 or more miscarriages, it is as high as 10 million, 1 crore couples with RPL. And if you consider 50% of them unexplained, then we have between 2 to 5 million couples who are with unexplained RPL only in India. So you can imagine the number, the magnanimity of the how huge is the problem, and we have to provide solution to these unfortunate couples. Then why consider immunotherapy? It was way back when Sir Peter Medawar, who is considered as the father of reproductive immunology and a Nobel laureate, he first time put forward this question that how does a pregnant woman manage to nourish within herself for many weeks and months a fetus that is antigenically a foreign body? All of you know that our immune system is protects us from any invader which is foreign from to us, and through a system of cells, tissues, organs which work together to defend the body against the attack by foreign invaders. But in pregnancy, this powerful defense system is overcome in mammals where the fetus grows in mother's body without any problem. How does this happen? Understanding how the maternal immune system responds to pregnancy is absolutely critical for our ability to better diagnose, understand, and treat various pregnancy complications. This is a very important diagram which tells us about the 2 parts of immune system, the activation and the tolerance or regulation. Activation is required for normal reaction against pathogens so that it protects our body, but at the same time, it should not act against our own antigens or our allogenic antigens, that is, no response to self or other harmless antigens like pregnancy or blood group. So this immunological equilibrium is absolutely important for protection against alloimmune and autoimmune diseases. And during last 25 years, it has become really clear that a large percentage of unexpected recurrent pregnancy loss may be due to alloimmune cause. And it has also been seen that more the number of miscarriages, more is the chance of alloimmune factor. Because this is obvious that fetus is known as, is termed as a semi-allograft, because the 50% part which comes from father is totally foreign to mother's body. But in spite of that, pregnancy continues unabated. In patients who have donor eggs, the pregnancy is 100% foreign, but still pregnancy continues without any problem. And this is indeed a paradox of pregnancy. And this is achieved by various mechanisms, but of which regulatory T cells, about which I will be telling very soon, play an important part in the continuation of pregnancy and preventing the reaction against pregnancy. This diagram shows various types of T lymphocytes which take part in the immune response. And we are aware about the Th1 type of cells which are inflammatory, Th2 type of cells which are anti-inflammatory. But these are irreversible cells and they cannot be converted into each other. But from the immunomodulation point of view, the Th17 and Treg cell ratio is what is the most important, because Th17 cells which are pro-inflammatory and Treg cells which are anti-inflammatory are relatively less stable and they are interconvertible. So this fact can be used to induce change, conversion of Th17 cells which are pro-inflammatory into Treg cells which are anti-inflammatory using immunomodulatory agents, and this helps in preventing miscarriage or implantation failure. So yes, we know why we require immunotherapy. So if we require, then in which cases of RPL or RIF immunotherapy will be beneficial? So let's see the diagnosis of alloimmune factor. In which cases you will, how will you select couples for immunomodulatory treatment? So there are a list of investigations. The level 2 means there is a level 1 where we do all the routine cases, routine investigations to rule out all the known causes. And then we come to the level 2 of investigations where the tests for alloimmune factors are done. This is a list of some of the tests which can be useful, though we use a specific 3 or 4 tests about which I will be telling you now. The first is the lymphocyte cross-match. This is the lymphocyte antibody detection test, and it is a comprehensive test that helps to establish the cause of reproductive failure if it is alloimmune. It measures the amount of antibody that reacts with protein of non-self, paternal or donor lymphocytes. And a negative lymphocyte cross-match in presence of unexplained RPL or RIF indicates an alloimmune cause, and that immunomodulation, for example, lymphocyte therapy, will be beneficial in such a case. The second test is natural killer cell estimation. Human NK cells have been identified as CD56 plus and CD16 plus or minus. So CD56 plus can be bright or dim. The CD56 bright are present in the peripheral blood while dim are present in the endometrial lining. And estimation of these cells or estimation of their activity by various tests can be used to select couples who have excessive natural killer cell activity by using either the proportion of NK cells or NK cell inhibition panel, or a specific test to know the NK cell activity called the K562 target cell test. So this will help us to select a couple. The third is endometrial NK cells. The NK cells in the uterine lining play an important role in implantation and maintenance of pregnancy. Yes, they are naturally present and they are important for normal pregnancy, but excess concentration and activity has been shown to be associated with repeated miscarriages. In fact, the CD56 dim cells which are present in the endometrial lining, they can maturate into CD57 type of cells which are otherwise normally not present in the endometrial lining. And presence of CD57 cells are highly cytotoxic and they are detrimental to pregnancy. In fact, now a newer test has been devised where estimation of CD57 to CD56 ratio is used as a predictor of the presence of alloimmune problem to select couples for immunomodulatory treatment. This can be estimated by a very simple test, endometrial biopsy in the luteal phase between 19 to 23rd day of cycle, and the endometrium is sent for immunohistochemistry for CD57 cells, which is done routinely in labs in India. The next test is estimation of a cytokine, inflammatory cytokine called called TNF alpha. It's a cytokine involved in inflammation and it plays a very important role again in maintenance of pregnancy and alloimmune rejection leading to repeated miscarriages. Increased production of TNF-alpha during pregnancy has been linked to not only RIF and RPL, but also with pregnancy-induced hypertension and gestational diabetes mellitus. Uterine NK cells also produce TNF-alpha and play an important role in inducing miscarriages and poor IVF pregnancy outcome. So the raised levels of TNF-alpha, various studies have shown, that studies by Kim and Daher, that significantly higher levels of TNF-alpha were observed in patients who had RPL, and levels of TNF-alpha should be brought to normal with immunomodulatory treatment and medications before planning pregnancy or IVF cycle. Treg cell estimation. Treg cells are one of the most important cells in maintenance of pregnancy, and estimation of Treg cells can be an excellent test which will help in predicting the course of pregnancy, which can tell about the prognosis of pregnancy, though we don't have currently this test available with us in India. But these good levels of Treg cells are essential to prevent production of autoantibodies in autoimmune diseases and also protection in alloimmune rejection. So following the Treg cell concentration or levels will be a very important test for detection of RPL or RIF. So with this test, we know whom to give immunomodulatory treatment or immunotherapy. Once we know who will be benefited, how do we give immunotherapy? So that is how immunomodulation done in RIF or RPL. Immunomodulation incorporates all those therapeutic interventions aimed at modifying immune response. So it's a big list of things which many of which we practice, but which act through immunomodulation either in active way or passive way. But most of the things in the list are passive immunomodulators, while the first one, lymphocyte immunization therapy, is an active immunomodulation. So I will be speaking about 2 or 3 important immunomodulatory methods here. The first is the lymphocyte immunization therapy. This was the first therapy which was recommended, immunotherapy which was recommended for repeated pregnancy loss, and it was in practice rampantly till maybe end of 2000. Because this is the first immunotherapy treatment that was used, it involves immunization of the prospective mother with allogenic mononuclear cells, and it is performed using paternal or donor lymphocytes, and it's the, as I said, most studied, researched and discussed method. It's a simple daycare procedure done at the timing of the procedure is not related to menstrual cycle. It's involves basically blood collection from husband or donor if husband is not able to donate blood. And these lymphocytes are separated by a special protocol. The separated lymphocytes are then injected in wife intradermally through multiple injections on forearm. And the entire process lasts for around 3 to 4 hours. There are various ways this procedure is done in different centers globally. There are centers which do multiple sittings, while in our center we do a single sitting procedure because of our patented specific protocol. The precautions are prior immunological testings are done, infection profile is done, blood group is done to know if your wife is Rh negative and husband is positive to give anti-D. And the couple is advised to plan pregnancy 4 to 6 weeks after therapy, preferably within next 18 months because the effect lasts that long. Booster doses may be given during first trimester in certain cases, while LIT also can be given during pregnancy if the patient presents first with pregnancy with history of previous miscarriages. How does it act? It acts by various mechanisms. Basically, there's an important role of dendritic cells. When these lymphocytes are injected into the skin, they're picked up by dendritic cells and they are presented to the immune system. There is Treg cell activation and there is development of blocking antibodies. As this diagram shows, the allogenic lymphocytes are picked up by dendritic cells. Then there is these lymphocytes then undergo activation and proliferation, and which leads to further antibody production known as the blocking antibodies or asymmetric antibodies, which help in preventing immunological reaction against the pregnancy. They tend to they coat the paternal antigen, or they prevent they competitively inhibit the symmetric antibodies which are present in the body and prevent rejection of pregnancy. Is it safe? Absolutely. We have been associated with more than 1,000 procedures by now, and apart from minor local allergic reactions, occasional mild malaise, no serious allergic reaction has been noted, no graft versus host disease In fact, a large study of 4,500 cases by Kling from Germany has shown there is no incidence of anaphylaxis, autoimmune disease, or graft versus host disease. But there are certain controversies associated with this procedure. And in 1999, there was a large study called REMI study, also called OBER study, which put forward, which was published in Lancet, and the conclusion was the history of unexplained recurrent miscarriage. Nearly 65% of control patients showed good results compared to only 45% who were treated. So the study showed that the control group did well than the treated group, and because of lack of benefit, it recommended against use of LIT. But this study faced a lot of criticism because there were a lot of irregularities in the study, because this is the only study published till date which has observed a negative effect of LIT on the rate of live births. The study used lymphocytes from stored blood, and when the blood is stored, the CD200 marker, which is important for immunomodulation on the paternal mononuclear on the lymphocytes, gets destroyed, and therefore when the blood is stored, it becomes the immunomodulatory effect goes away, but those cells were used. The study did not exclude patients with autoimmune disorders. The ANA positive patients were not included. There was lack of post-immunization control. Lymphocyte concentration was not fixed. The dosage, the route of administration was not fixed. So therefore, this study faced a lot of criticism. But this study was subsequently became the basis for Cochrane reviews in 2003, 6, and 14, which recommended against use of immunotherapy for repeated miscarriages or recurrent implantation failure. Unfortunately, the Cochrane review itself was not without flaws. And though this Cochrane meta-analysis showed an odds ratio of 1.22, which was quite poor, there were a lot of flaws in Cochrane review which were pointed out by various researchers, including Dr. Christiansen. Like the Cochrane review studies never considered the type of miscarriage, whether primary or secondary, the number of miscarriages, the immunizing dose, the route of administration. So all those things were not considered. So therefore, the results were skewed. That's what was the objection of various researchers. So if we have to give now immunotherapy, is there any recent evidence to corroborate it? We know there were controversies, but what does the recent evidence say? And I went through literature over last almost 25 years. And between 1997 and 2005, I got 10 studies which said it is majority of them said it is beneficial. Between 2006 and 15, there were 8 studies which were absolutely for lymphocyte immunization therapy. While in the last 5 years, there were almost 12 studies which said majority of them said that LIT is beneficial for patients who had recurrent pregnancy. So all recent studies are indicating towards the usefulness of lymphocyte immunization therapy. The recent evidence, the recent meta-analysis threw more light on this. The meta-analysis by Liu showed a success of 77.8%, and as the diagram shows, the odds ratio of 4 was seen in the meta-analysis by Liu, which proved the efficacy of LIT. Further, in 2017, a newer meta-analysis by Cavalcante, which included the OBER study, it showed a significant improvement in the live births in couples treated with LIT, as shown in this figure, where the odds ratio was 3.13, again, which underlined the efficacy of the lymphocyte immunization therapy. Both these recent meta-analysis concluded that LIT is a safe treatment. It is valid treatment for couples with repeated miscarriages. It is beneficial when given before and during pregnancy, and best results are obtained when the lymphocytes are given in adequate number and fresh lymphocytes are used. And it is beneficial, but it is beneficial in well-selected groups. The subgroups of patients must be identified properly for the efficacy of this treatment. One more study by Sarno also underlined the efficacy of LIT, where they used patients, more than 1,000 patients of RPL were analyzed, and it showed that LIT in pregnancy also gives significantly improved success rate. But careful laboratory tests should identify subgroups of repeated miscarriage patients most likely benefited by LIT and exclude those with likelihood of benefit. I would like to lastly share one more recent review by Professor Howard Karp from Israel. And in his paper, he has clearly said that when used on an unselected population, immunomodulation may not affect the live birth. But when women with repeated miscarriages are selected with immune phenomena with the investigations, immunotherapy has been shown to be effective. Embryonic aneuploidy is a prevalent cause of miscarriages. So failure to account for aneuploidy has resulted in immunotherapy showing poor results. So that has to be taken into account. And there is no definitive biomarker as yet, though there are so many tests. There is nothing, no 100% definitive biomarker for which using which patients can be selected for immunotherapy, and more investigations are required for that. So therefore, he has recommended a research agenda where different type of NK cells require more research to find out the required levels. The Treg cells are more important, so more investigation, more research should be done in the field of Treg cells, which can then become the basis to select couples for immunomodulatory treatment. And different types of immunomodulatory therapy require refinement to determine the exact dosage and most efficacious regimen. So yes, this was about lymphocyte immunization therapy, but there are other immunomodulatory medications which can be used along with it, especially when they are used along with active immunomodulation. They enhance the immunomodulatory effect. One of them is immunoglobulins. All of us are aware immunoglobulin is a preparation made from sterilized, purified human plasma from thousands of healthy donors. And it is used in the treatment of recurrent implantation failure and recurrent pregnancy loss, where the immunological factor is considered. So it acts by various mechanisms. It modulates the complement activation. It suppresses the idiotypic antibodies, blocks macrophage C receptors. In effect, it has action on cytokines, chemokines. So it suppresses the action of natural killer cells. And through that, it produces immunomodulatory action. Intravenous immunoglobulins has been associated with a lot of side effects like thrombosis, renal dysfunction, or transmission of diseases, and it's contraindicated in presence of allergy or renal dysfunction. So an intramuscular immunoglobulin has been in use where in patients with repeated miscarriages and recurrent implantation failure, which acts in the same way by decreasing the by binding with the Fc receptors of dendritic cells and producing anti-inflammatory effect, and decreasing the activity of natural killer cells, thus reducing the inflammatory serum TNF alpha levels. So this is used in the intramuscular form. Intralipids have also been recommended in patients who have RPL or RIF. This is a fat emulsion containing soybean oil, phospholipids, and glycerin water. And it is known to decrease again the raised natural killer cell activity and reduces the Th1-Th2 ratio, thus preventing RPL and RIF. And this, at many centers, this has been used as an alternative to intravenous immunoglobulins. So these are the other two immunomodulatory agents which are used commonly. The mechanism, as I said, it acts on the inhibits the pro-inflammatory Th1 cells and also suppresses the natural killer cell activity by activating PPAR receptors expressed by the NK cells. So this is how it produces this anti-immunomodulatory effect. So in summary, I think helping the body to help itself by optimizing the immune system is of utmost importance. Unfortunately, no immunomodulator is available which fulfills all the standards, but it needs extensive research and development of compounds. And immunomodulation in pregnancy, for sure, is going to play an important role in the management of RPL and RIF in future. Thank you very much for your patient hearing.
Thank you, Dr. Mohan, for such a nice and innovative talk. And I think immunomodulation has been used since a long time, not long time, but very frequently by many of the gynecologists, and they really make very successful stories in infertility and RPL. And this IVIG, I think, very expensive one, but not very good. But people do recommend this. Even research centers, I think, aims people may be using it. And then IMIG also being used, and this lit therapy therapy is definitely, I think, I have seen many of the infertility center using it. Thank you, sir. Thank you very much. And I think in the future it does it will be the main therapy along with all the ART, especially.
Thank you, madam. We are also awaiting the results of our research, our case studies. So very soon we will come out with the our data. So that will also underline the success.
Uh, Dr. Raut, I have a slightly different take on this. I'm sure that when you have been talking to so much of the medical audience, any new therapy or any new technology is often met with skepticism and rejection. Now, what at present, if we look at very rationally, what at present therapy do we have for these childless couples or these couples who are going through so much of trauma of rejection and failure every time they try a pregnancy? We really don't have something.
Definitely.
Immunotherapy is the only hope where we can give them some chance of achieving a pregnancy, and I think we should. And it's totally ethical. It's not something which is not ethical. It has been scientifically researched, and I think it may not give you 100% results, but for that individual couple, for them it is 100% success if they are able to achieve a pregnancy. And I think Dr. Raut has showed us right from the level of the cellular biology up to the level of clinical evidence and the take home pregnancy rate. Immunotherapy is advancing day by day. It is being more successful day by day. It is becoming more cost effective day by day. And I congratulate Dr. Mohan Raut, who over so many years has constantly shown his passion and his persistence in endorsing this particular therapy. And I'm sure his patients must be blessing him for the joy of parenthood that he has handed over to them. Thank you, Dr. Raut, for this enlightening talk and for this wonderful explanation of immunotherapy.
I would welcome Professor Krishnendu Gupta sir's opinion, because sir has been in practice for, I think, decades. Probably he has more years of practice than I have on this planet. If I could summarize.
I think Pratik caught me there. I really wanted to congratulate Dr. Mohan Rao, just like Amaya and Archana have done. I think it's fantastic work that you're doing. Of course, expense must be a problem. And I personally don't have much experience at all with such therapy, because these are specialized therapy. And I think people who are really, and I think a time has come where people who are interested in such research and work should be given the opportunity to, flower even more with such presentations. And although you had written, your topic as immunotherapy simplified, but just by going through your, just the data and the names, I think even Archana went into a tizzy, and so did I. And of course, Amaya, I think, loves immunotherapy the way he was speaking. And all of us, it's really something new, and it's obviously, I always say, just like some new vaccine. So we keep wondering what's going to happen next, and what more we are going to get out of all this. But definitely, there is a role of immunotherapy in RPL, and I'm glad that people like you have dedicated your entire, life in obstetrics, thinking of this, because not very many of us are actually interested in too much of immunology. We as clinicians want to know whether a vaccine works, whether this happens, that happens, and we are very happy to prescribe the product. So it's I'm really, I'm very happy to give a comment on your presentation, which is really wonderful, and I hope we can learn from each other like this over these lovely webinars, which Pratik and AMOGs are really going ahead in gung-ho fashion to, whenever I see Pratik's phone ringing, I know, oh my God, one more. So it's like that, and thank you very much, Pratik, and of course Amaya too, because he's a really big person in AMOGs. I think we can go on to the next presentation with the permission of Pratik.
Yes, sir, please go ahead. I think Dr. Archana Verma wanted to say something.
Yes, I just wanted to say this allo-immune system really needs a lot of this workup for everybody. This क्योंकि जब कुछ समझ में नहीं आता तो ऐसा ही लगता है कि बस autoimmune disorder ही हो गया है.
Hopefully, during the course of our lifetime, we will be able to unravel that mystery.
Yes, each section is itself is a topic of seminar, and anyway, we hardly know much about immunology till today. I think our knowledge
Yes.
about immune system or immunology is still very, 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 very less. And I think in the
Yes.
years to come, we will more things will unravel. And I think uh, let's see.
So we'll take the audience questions at the end in the Q&A session, sir. We would request that you stick around. And without
Okay.
further ado, I would request Professor Krishnendu Gupta to introduce the second speaker, Dr. Sujata Dalvi. Madam has an event to attend where I think Professor Abhay Dalvi is being installed as the president of the Association of Surgeons of
No,
India.
no,
And we
no.
shouldn't keep
He's
her.
no, not install. He is just inaugurating a session for UP chapter of Surgeons of India. So he's at the inauguration, but he's almost finished. So not a
All right.
problem.
Fantastic. Session, can we have the slide share?
Yeah.
Okay. It's a great honor for me to introduce Dr. Sujata Dalvi, whom I keep meeting in conferences and now, of course, through webinars. She is a consultant obstetrician gynecologist from Mumbai and is associated with quite a lot of hospitals, the Global, Saifi, Bhatia, St. Elizabeth, Rukshmani, Lying In, and Jain group of hospitals. She's an honorary clinician associate at the Nauroji Wadia Maternity and Jagjeevan Ram Railway Hospital, an assistant editor of Jogi, and we see her a lot in the Jogi meetings as well. She's a member of the Managing Council of Mumbai Obstetrics and Gynecological Society for the last 15 years, and the first joint secretary of AMOGS, which is the Association of Maharashtra Obstetrics and Gynecological Societies. And as we all know that Dr. Sujata Dalvi will be speaking on the modern management of preterm labor. We know a lot of new things keep coming up about preterm labor, PPROM, PROM, and etc. And we would love to hear Dr. Sujata Dalvi. Dr. Sujata Dalvi, please.
Thank you, Krishnendu. It's my privilege to be introduced by you. And at an outset, I would like to thank the president of AMOX, Dr. Nandita Palshetkar, and the secretary, Dr. Arun Naik, for giving me this opportunity. And of course, the convener of today's program, Dr. Pratik Tambe. So I'll be speaking on preterm labor. I would like to share the slide, please. Yeah. Yes. So after a very lucid talk by Dr. Mohan Raut, this patient who has had a recurrent pregnancy loss, now that she has conceived and then she goes into a preterm labor or maybe threatened preterm labor, and we should know how to go about it. Okay. So as any doctor can tell you, the most crucial step towards the having the right earlier diagnosis by an appropriate screening, the disease is precisely identified and a good resolution is far better. And conversely, a late diagnosis usually means a very bad outcome. And this shows how skilled the physician is. This is what has been told by Andrew Wells. So what exactly is a preterm labor? WHO defines a preterm labor as all births before 37 weeks of gestation or fewer than 259 days from the first day of women's last menstrual period. And preterm labor is responsible, mind you, almost about 75% of neonatal mortality. That is quite a bit of a neonatal mortality. Preterm babies are defined as a late preterm, that is after 34 weeks up to about 36 weeks. Moderately preterm is between 32 to 34 weeks. Very preterm between about 29 to 31 weeks. And extremely preterm is 28 weeks. And mind you, almost about 80% of preterm babies have which are moderate or late are being born between 32 to 36 weeks of pregnancy. So mind you, almost about the preterm birth that happen, almost about 80% are born between 32 to 36 weeks of gestation. Preterm labors could be as spontaneous, where approximately about 40 to 50% are because of spontaneous preterm with an intact membrane, and 25 to 40% could be due to preterm premature rupture of membranes. And there could be some indication whereby which you have to carry on a preterm birth, and it could be a deliberate intervention for variety of maternal or an obstetric indication, and this incidence is almost about 20 to 30%. If you see worldwide, almost about 11.1% of infant born preterm every year as such, And preterm birth is a leading cause of major perinatal morbidity and mortality. It's the second most common cause of death after pneumonia in children under the age of 5 years as such. So mind you, preterm forms are very important so far as perinatal mortality and morbidity is concerned. If you see the country of India as such, India comes as almost about proportion of global live births. We are about 18.5%, and proportion of preterm rate is almost about 13.6%. So if you go to see Southeast Asian countries, including India, China, Nigeria, Bangladesh, and Indonesia, they account for almost about 57.9 million of preterm births globally as such. And this is a study which was carried out in 2014. If you go to see why does a preterm birth happens? Preterm birth happens, one, because of the activation of maternal and fetal hypothalamic pituitary axis as such, and it causes preterm onset of physiological contractions. It also leads because it can also happen because of an inflammation or an infection which brings about choriodecidual reaction, and that can also lead to a preterm labor. It can also happen because of a decidual hemorrhage which leads to abruption, and that sets off a contraction, and preterm labor can happen. Or it can also lead to because of an overdistension of uterus like multifetal pregnancy, polyhydramnios, and uterine anomalies, which itself brings about some sort of an decidual reaction and which can set the uterine contractions. What are the risk factors so far as preterm labors are concerned? Any patients who have had a previous history of preterm labor, she is more prone to have. If you have a short cervical length as such, which is diagnosed maybe early in the second trimester, then these patients are likely to go into a preterm labor if they are not treated. Uterine anomalies like a septate uterus or even an biconjugate uterus or even a uniconjugate uterus, these patients also can go into a preterm labor. They found age less than 18 or age, especially patients who are more than 35 years, and if they've conceived, they are likely to go into a preterm labor. Any patient who has had a vaginal bleeding, for whatever may be the reason, she is likely to go. Multiple gestation, I've already told you. They found pregnancies which have conceived because of an ART treatment. These are the patients also may likely to go into a preterm labor. And any patient who has had a preterm premature rupture of membranes, these patients can also go into preterm labor. Now, any patients with previous history of premature birth, if they've had a genital or a lower urinary tract infection, these patients can go into preterm labor. I've already said vaginal bleeding, I've already said lifestyle modifications like cigarette smoking. These are the patients, if they continue to smoke during pregnancy, they can go into preterm labor. Very high or very low BMI, these patients are also likely to go into preterm labor. Low socioeconomic status patients, they have found out they are likely to go into preterm labor. Probably they have more of a physical activity or more of a physical or manual work as compared to the other ethnicity. They have found that patients of a Southeast Asian countries are likely to go in more incidence of preterm labor. Patients where fetal fibronectin test, if at all it is done and it is found to be positive, these patients can have more incidence of preterm labor. And any surgeries which are performed on the cervix, like conization of cervix, or if they've carried out a Fothergill surgery and patient has conceived, these patients can go into preterm labor. If you go to see preterm labor, the cause is almost unidentified in almost about 50% of the patients who have gone into a preterm labor as such. And majority of the patients where women with the risk identified, then they don't go into a preterm labor, and women with preterm labor, they've got no risk factors as such. So it is very dicey whether which patients can go into preterm labor, and that's why it is very important to make a proper diagnosis and give them a proper treatment as such. Almost about 50% of patients who go into preterm labor are spontaneous with an intact membrane. Only about 25 to 40% of the patients have preterm premature rupture of membranes. Hence, if you go to see, preterm labor is very difficult to screen, very difficult to predict, very difficult to prevent, and you need to identify and treat these patients. Now, how do you make the diagnosis? Diagnosis is one, you need to predict. If they give a positive history of a previous preterm labor, then you have to be little proactive so far as trying to find out whether the patient has any possibility of going into preterm labor or no. So clinical, one is from the history. On a clinical examination, presence of, in case you find active uterine contractions, and if you do per vaginal examination, if you find open os as such, or if the membranes are bulging, then you know that this patient is likely to go into preterm labor. Now, there are certain patients who will not complain of anything, but when these patients, especially when they go for an anomaly scan and when the transvaginal sonography is done, especially in the second trimester, if you find cervical length which is less than or equal to 2.5 centimeters, if there is coning of a fetal sac, if the internal os is little bit open as such, or if you find a U-shaped internal os as such, then these are the patients who are likely to go into preterm labor. Some sort of a treatment needs to be given as such. More predictive value would be a patient who has had a preterm, contractions, uterine contractions, patients who have had a premature rupture of membranes as such, and these are the patients who may go into a preterm labor. And another test, in case you are dicey about whether this patient is likely to go into a preterm labor, she comes with a history of uterine contraction. If there is a possibility of getting a biochemical test like fetal fibronectin test from cervicovaginal secretion, or if there is an identification of phosphorylated IgBFP, that one protein that is known as an actin parters test. And in case you find any test results which are positive, then these are the patients, if they are not treated, are likely to go into preterm labor in next 1 week time or so. So if you go to a cervical vaginal sonography, so far as cervical length is concerned, it forms a very important part so far as to predicting a patient with a preterm labor. Shorter the cervical length, greater are the risk of a preterm labor, and they have found out any cervical length which is less than or equal to 2.5 centimeters, you should also always consider doing what we call it as an os tightening. Otherwise, these patients, if they are not treated well, are likely to go into preterm labor as such. Now, something which is known as a rescue cerclage, as what I said, if the internal os is open, if the membranes are bulging, if you find a U-shaped internal os, these are the patients where the cervix is already dilated, the membranes are a little bit protruding outside, and these are the patients, if they are left all alone like that, then these are the patients who are likely to go into preterm labor, and you need to do a rescue cerclage where you need to admit the patient, you give her a head low position as such, so that hopefully the sac would recede inside, and then you do a very gentle os tightening as such, but keeping a sponge holder with a gauze piece inside, and just slowly and gradually remove the sponge holder when you are tying the cervix as such, and that is known as a rescue cerclage. At the same time, you can give tocolysis, you can give progesterone also, and keep the patient under observation. You should not try and do rescue cerclage if there is any sign of infection as such, if there is active bleeding, and if the uterine contractions are present. Once you treat the infection, once the active bleeding is treated, or once the uterine contractions quieten down, and then one can try and do rescue cerclage, you'll have a better results as such. Now, how do you make a diagnosis from a biochemical investigation? Fetal fibronectin from vaginal, cervicovaginal secretion, or actin parters test, I've already told you. Sensitivity of both these tests is almost about 95%. Specificity is about 92%, and this is a bedside result which gives you result in almost about 5 minutes. The fetal fibronectin test is not available everywhere, but actin parters is available and it gives you. And here the positive predictability is not very specific, but negative predictability is very specific, that in case you have a negative result, it means this patient is unlikely to go into a preterm labor, whereas if you have a positive result, this patient may or may not go, depending upon what treatment would you like to give it to, what treatment is being given to the patient. So fetal fibronectin, it's an extracellular matrix glycoprotein which is found between chorion and deciduum, and if at all it is present in the vaginal fluid, it means that there is some sort of a decidua chorion separation, and this patient may go into a preterm labor. So you have to be a little more proactive so far as treating these patients is concerned. But this test is not very easily available everywhere. You just have to collect the vaginal secretion, cervicovaginal secretion, put it into a test tube which is filled with a normal saline, and there is just as we do a urine pregnancy test, the same kit is available. You just have to put 2 or 3 drops. If you get 2 lines, means it is positive. If you get 1 line, it is negative. Again, I'm repeating that if it is single line, means it is negative, it means patient is unlikely to go into preterm labor in next 2 weeks time as such, and negative predictability is much more accurate as compared to a positive predictability as such. Coming to any patient, in case a patient has had a uterine contractions at a very early age, or in early weeks of pregnancy, or she has had some sort of a sequelae, a leaking PV, or some sort of an excessive discharge, any patient who complains of this, first and foremost, it is better to admit this patient rather than sending her home. So any patient who complains of anything, you admit the patient for an observation. Consider if at all there is possibility of in utero transfer. In case you don't have a possibility or you don't have a facility for an NICU, and if you feel that the patient is likely to go into a preterm labor, it is better to transfer the patient where in a tertiary healthcare center where the neonatal facilities are available as such. In case patient complains of any pain, you can offer an analgesia. Always better to administer corticosteroids for fetal lung maturity as such. If at all there is a feasibility of getting a transvaginal sonography, find out what is the length of a cervix, and that way you can predict what exactly is to be done. Discuss the plan with the patient as well as with the relatives, document the same thing, and clinical reassessment, that is in case the patient is admitted, try and reassess the patient every 4 to 6 hours, 12 hours, or every 24 hours depending upon the symptoms of the patient. Now once the patient is admitted, tocolysis plays a very important role for any patient with a threatened preterm labor or with a preterm labor as such. Why tocolysis plays a very important role? Because it gives you a time for to transfer the same patient in a tertiary healthcare center where NICU facilities are available. It also allows the action of corticosteroids on the fetus so that the fetal, in case patient delivers prematurely, baby will have a better prognosis. And third thing, in an extreme preterm labor, it also allows one to give a magnesium sulfate administration, which not only acts as a neuroprotection as such, but it also at times reduces the uterine contractions. Now, role of antenatal steroids, very important. You need to give betamethasone 12 milligrams intramuscularly every 24 hours, or dexamethasone 6 milligrams intramuscularly 12 hours for 4 doses. The previous one is for 2 doses. Give it between 24 to 36 weeks. We generally give it between 26 to 36 weeks, where the patients have a risk of preterm delivery, or those patients with a ruptured membrane, or those patients with a multiple pregnancy prophylactically. Also, there is no harm in giving an antenatal steroid. If at all one has given a single dose, one can give a additional dose if at all it is required, that is after 34 weeks, if at all the previous one has been given at around 28 weeks or so. They have also found decrease in the, so far as neonates are concerned, they found decrease in the respiratory distress syndrome, intraventricular hemorrhage, or even decrease in the neonatal infection in case the steroids have been given to the patient. And steroids have got a very limited use in a patient who have got a multiple pregnancy, in a very obese patient, or a patient who has had a growth retarded fetus as such. So if you go to a tocolysis, calcium channel blockers, that is, and nifedipine is the commonly used tocolytic agent nowadays as such. One, because it is very easily available, it can be given orally and it is very cheap. Though nifedipine has not been put under the banner of a tocolysis, but it gives a very good result as such. So everybody has been, we have been using nifedipine as a first line of therapy so far as tocolysis is concerned. You start off with a dose of 20 milligrams, wait for about 30 minutes, see if the contractions are present, and then repeat the dose after about half an hour or so. Or in case the contraction ceases, then you can repeat the dose after about 3 to 4 hours, and you can give it to almost about, say, about 24 hours or later on. Sometimes a maintenance dose is needed between 20 to of about 20 to 40 milligrams every 6 hourly till the uterus quietens down or till the uterine contractions are not there. Only side effect of nifedipine is it can give rise to headache, it can give rise to little bit of a dizziness, because it does bring about lowers down the blood pressure as such, can bring about flushing as such, it can give about rise to reflex tachycardia, and sometimes it can give rise to systemic hypertension. But when you give orally, more or less you find a good results, and none of these side effects are seen to that much of an extent. In case patient has been given magnesium sulfate as such, then one need not be administered along with calcium channel blockers, because both magnesium and calcium, sometimes they have an additive effect as such, and sometimes a calcium channel blocker, that is nifedipine, may not have that much of a proper effect. So it is better to wait till the effect of magnesium sulfate goes off and then start off. Or when you're trying to give magnesium sulfate, and if you have already given nifedipine, wait for about 2 to 3 hours and then start off with magnesium sulfate as a neuroprotector. The second commonly used tocolytic agents is beta sympathomimetic drugs. These drugs, we have been using it for so many years, ever since we have started with the residency. only last about 2-3 years that we have shifted over to nifedipine. That is because of the side effects of beta sympathomimetic drugs. The commonest drug which is used is isosuprene hydrochloride. It's available as oral and injectable. You can give injectable as 10 milligrams, available as 2 ml ampoules. You give it IV, about 20 to 40 milligrams in 500 cc's of 5% glucose, but you need to monitor the patient very well because it leads to hypotension and tachycardia. In case you are giving oral tablets, you need to give 10 milligrams every 6 to 8 hours as such. There are some people who just try to give oral tablets as a maintenance dose for almost about 3 to 4 weeks, even after the uterine contractions have stopped. The side effect would be hypotension and tachycardia. This drug has not been very widely used, but there are some people who still use this drug as such. The third drug which is used is an prostaglandin synthetic inhibitors, that is indomethacin, which is an NSAIDs. We have not been using it, but there are some people who have got very good results and they have been using it as 50 to 100 milligrams orally, followed by 25 to 50 milligrams every 6 to 8 hours as such. You give it for almost about 48 hours. The side effect would be severe hepatic and renal impairment, platelet dysfunction as such, gastritis and GI ulcer. But there are some people who are very happy with using indomethacin as such. The side effect would be nausea and gastritis. Only side effect of using indomethacin for a long time is it can give rise to ductus arteriosus closure. It can give rise to an oligohydramnios, hyperbilirubinemia, and altered renal function. The only time we have used indomethacin is in a patient of a polyhydramnios, where you feel patient is likely to go into a preterm labor as such. The newest drug which is available in the market is oxytocin antagonist, which is known as an etosiban. This drug is specifically developed for tocolysis and it is utero-specific. Rest of the tocolysis, which I have already spoken, have got some sort of a systemic effect on some other system as such. Whereas this is one specific drug which has been totally utero-specific as such. It acts only onto the uterine myometrium and it has got maternal and fetal safety as such. It's the safest choice in a patients who have got multiple pregnancy or patients who have got anemia and with pregnancy as such, because other tocolytic can predispose to pulmonary edema, whereas this is one drug which does not act on anything else except onto the uterus, and hence these are the patients who are at a high risk. This drug can be easily used. The onset of action is within 10 minutes. It quietens down the uterus as such. The side effects are much less. If at all they are present, it can lead to nausea, vomiting, headache, hypersensitivity and dizziness as such, but fetal and neonatal side effects are almost nil as such. The only problem with etosiban is, sorry, only problem with etosiban is it gives rise, it is little on the expensive side, and that is the only problem with etosiban. Otherwise, etosiban really works out very well. It can be used as a loading dose, as an intravenous infusion. It's available as 0.9 ml, and the second one ampule is available as a 5 ml. So you first give that 0.9 ml IV infusion over a period of about 3 minutes as such, and then you give the loading dose of 37.5 milligrams per 5 ml. So you put about 7.5 ml. So you have to break another 5 ml ampule, take only half of it and leave the half of it in the refrigerator, because you need to give it over 48 hours. So you can utilize that 2.5 and break another ampule of 5 ml. So that makes it almost about 7.5 ml on the second time as such. So 7.5 ml in 500 cc's, you give 60 drops per minute for about first 3 hours, and then you just reduce it to almost about, so 5 times less, almost about 12 drops per minute in next 48 hours as such. In case you have a 100 ml normal saline solution, you can use 12 drops per minute for next 3 hours, and then you reduce it to almost about 4 drops per minute for next 48 hours. So totally etosiban needs to be given for 48 hours. Most of the time after giving etosiban, patient responds very well and uterus quietens down, and then you can give some other therapy once the uterus quietens down. The only thing so far as tocolysis is concerned, one needs to remember is you can use only one tocolytic agent at a time. So whatever you may be comfortable, if a patient can afford etosiban, fine. If you're comfortable nifedipine, fine. If you're comfortable with duodenal, fine. Whatever you are comfortable with, you can use tocolysis only one at a time. You cannot be using a combination of a tocolysis to have a better result, because you will end up with more side effects rather than having the effect. And in case there is a possibility of vaginal infection, or if you find that there is a possibility, then it is better to treat. So simultaneously, you can start antibiotics on the patient while treating patients who have got a premature preterm labor as such, or what we call it as a threatened preterm labor. Now, after the uterus quietens down, after you have given the tocolytic to the patient as such, now what do? So there comes the role of a progesterone. Only when the uterus quietens down, then you can start off with the progesterone. The commonest progesterone which is used is injectable progesterone, 17 alpha hydroxy progesterone caproate, which is a long acting. You give it about 250 milligrams intramuscularly weekly. You can also give natural micronized progesterone, that is either oral or vaginal. You can give 200, 300 or 400 milligrams. The main advantage of using progesterone is it relaxes the uterine myometrium, it blocks the uterine oxytocin activity, and inhibits the gap junction, and it also has an anti-inflammatory activity. A trial was conducted in 2003 where they had given patients with a high risk group of patients for a preterm labor in a singleton pregnancy, and they gave progesterone 250 milligrams intramuscularly. They started giving from 16 to 20 weeks onwards till almost about 34 to 36 weeks. And they have found very decreased incidence of a preterm labor in those patients where progesterone was given. And that rekindled the interest of role of progesterone in a patients who have had a threatened preterm labor. So the main action of progesterone would be it decreases the conduction of contraction, it increases the threshold for stimulation, it decreases the spontaneous activity, and it decreases the number of oxytocin receptors, and it also prevents the formation of gap junction. Progesterone forms a very important role once the uterine contractions have quietened down, to prolong the pregnancy as such. Progesterone becomes a very important drug as such. This is another trial which has been conducted as such, where they had also given weekly progesterone injections in a patients who have had a prior spontaneous preterm labor, or those patients who were at a risk of having preterm labor, and they had given two groups. One had been given progesterone and another one had been given placebo, and they had found positive results in a patient who had been given progesterone as such. This is a meta-analysis also another showing the role of progesterone as such, and they have found reduction in the rates of the preterm labor in the group which was given progesterone. At the same time, they have found reduction in the rates of low birth weight in the group which was given progesterone as such. And this is another trial of EPIC trial where again progesterone was given, and they had found a positive result in the group where the progesterone has been given. So per se, if you go to see in a high risk patient with a preterm labor, you give 17 alpha hydroxy progesterone caproate intramuscularly weekly, 250 milligrams, or you can give natural micronized progesterone vaginally, 100 milligrams from 20 weeks onwards in a patient who are high risk with preterm labor but with a short cervix that is less than or equal to 1.5 centimeters. Of course, if there is a feasibility of doing an oostatin, one should do it, and at the same time start off with a natural micronized progesterone vaginally, 200 milligrams daily from 22 to 24 weeks onwards. And those patients where the preterm labor was proved, it was arrested with the help of some tocolytic agents as such. These are the patients you give 17 progesterone intramuscularly, 250 milligrams, but you give it twice a week. Of course, you get progesterone which is available even as 500 milligrams, but you can give 250 milligrams twice a week, and natural micronized progesterone vaginally in a higher dose, that is 400 milligrams, and later on after about 4 weeks or so you can reduce the dose as such. So per se, if you go to see progesterone, it is not very useful in a patients with a multiple pregnancy. So prophylactically, if you try and use progesterone in a patient with a multiple pregnancy, it may not be very useful as such. It is also not useful to halt the labor. That is, in case patient has got a very active uterine contraction, if you give progesterone, it will not help. It's only when the uterus quietens down, and then to maintain the pregnancy as such, progesterone would be useful as such. And it cannot be useful as an adjunct to tocolytic agents. That is, you have to stop the tocolytic agents and then you give progesterone. It will have a better effect. You cannot give tocolytic agents and then simultaneously give progesterone as such. So what is an ACOG's recommendation? That is, in a singleton pregnancy with a previous history of spontaneous preterm labor, progesterone from 20 weeks onwards should be given regardless of the transcervical a TVS cervical length, that is regardless of the cervical length, whether it is 2.5 centimeters or more or less, it is always preferable to give patients a progesterone in case the patient with a previous history of spontaneous preterm birth. In an asymptomatic patient, if the cervical length is less than or equal to 2 centimeters at around 20 weeks of gestation, it is better to give vaginal progesterone. In a patient with a multiple pregnancy, if you give progesterone, there is no reduction labor, and that is the reason progesterone as a prophylaxis is not recommended as such, and there is an insufficient evidence for an additive effect of cerclage along with progesterone to reduce the risk of preterm birth in a patient with a high risk preterm. So that is in case you just want to do a prophylactic cerclage as such, but when it is not indicated and you give progesterone, the additive effect is not there. But if you give only progesterone and in case cerclage is not indicated, you will have a better result as such. Coming to magnesium sulfate as such, magnesium sulfate acts as a neuroprotection of the baby, and it needs to be given between 24 to 33 weeks of gestation. That's what they recommend. I would still prefer to give it between 24 to around 32 weeks of gestation as such. It decreases the incidence of cerebral palsy, and the dosage of magnesium sulfate is 4 gram intravenously, IV loading dose over 20 minutes, the same thing what we use it for an eclampsia, and follow it up with an IV infusion of 1 gram per hour. It's like a Zuspans regime also. You give it till the birth of the baby, or at least you give it for about 12 hours, whichever is sooner, and then you take up a patient. For in case a patient is for a section, you need to take up a patient later on as such. Only if in case a patient is been taken for a section and in case general anesthesia has to be given, you need to inform the anesthetist that magnesium sulfate has to be given, because sometimes it comes in the way of they are giving general anesthetic agents. You need to monitor the side effects of magnesium sulfate, same like how we monitor the eclamptic patients as such. And now magnesium sulfate has been found to be a better neuroprotection so far as the preterm babies are concerned. So what does an ACOG recommend so far as preterm labors are concerned? Individualize the treatment depending upon the maternal condition. You cannot have a similar treatment, but you need to individualize the treatment. Tocolytic drugs with a less of side effects needs to be used as such. So with whatever you are comfortable with, you can continue using it. There's no hard and fast rule that you need to give only a particular tocolytic agent. As long as you are comfortable with and patient gets a relief, you can use it. There's no maintenance with tocolytic drugs. That is, once the uterine contraction ceases, you don't need to use the tocolytic drugs. What you need to use it is a progesterone supplement so as to maintain and continue with the pregnancy. And success of a patient with a preterm labor is if you initiate the treatment as soon as possible. So it's very important. The first slide which said, if you make a diagnosis, initiate the treatment. If you make a late diagnosis, sometimes it's too late by the time you start with the treatment. It may not have that much effect as such. Administer steroid. This is very important so far as the proper neonatal outcome is concerned. Administer magnesium sulfate if and when it is necessary. And in case your center does not have a proper NICU facilities, after giving all the treatment to the patient, try and transfer the patient to another center where the NICU facilities are available. And before you transfer the patient, make sure that the NICU bed is empty. We have had patients where the patient has been transferred and there is no NICU bed and patient goes from one hospital to another. So before you transfer the patient, make sure that NICU bed is available. Then only transfer the patient so that the patient doesn't have a problem of going from one hospital to another when the NICU bed is not available. Thank you so much for a patient hearing.
Thank you very much, Dr. Dalvi, for this, very, very comprehensive, overview of preterm labor. And I'm sure there'll be a few questions. I have just two points to make. One is, of course, magnesium sulfate. I mean, I'm so glad you highlighted it about neuroprotection, but it also acts as a tocolytic. So that's one of the great advantages of magnesium sulfate, that when you give magnesium sulfate, you don't have to give another tocolytic. And it was excellent that you highlighted that you need to give only one tocolytic at a time and not a combo, as you called it. Another issue which we have found, of course, Ameya will bail me out here, or Pratik, because they are the youngsters practicing obstetricians, is about atosiban. You did give the very, very elaborate dosing schedule. Number one of the biggest problems is the dosing schedule. Our residents are so happy giving that 40 milligrams of isoxsuprine and then just monitoring the drip and being happy about it. that they actually don't, because IV infusion of 6.7 milligrams to that 0.9 mils over 1 minute, and then 300 mics over 3 hours per minute. I mean, it's really gives a lot of confusion. Then break one amp, you take half of it. So all that drama, they just, okay, patients come, start isoxaprine drip. And that is why I think atosiban has taken a big hit in our country. Of course, it's a little, it's quite a bit more expensive than isoxaprine. But I think this is a personal experience which I wanted to share, and because I want the youngsters like Ameya, Pratik, and of course, Prof. Dadwal is there from AIMS. I mean, she's also got huge knowledge and experience. But this is a reaction which I wanted from you all. What is the ground reality regarding atosiban?
It's not very different in our part of the world. It's pretty much the same.
Yeah, it's not very difficult as such. You just have to take 2 ampoules of 5 ml, keep the 2.5 ampule in the fridge. You first start off with either 500 or 100 ml, whatever it is. Start off with 60 drops for first 3 hours. The drip rate is set, there's no problem as such. You have a drip rate where you can find out. And then later on, continue with the same drip after about 3 hours as such, at exactly 1/5 of whatever you have started, and continue for about 48 hours, and you get excellent result as such. Only thing, keeping that half ampule in the refrigerator and taking it out is a little bit of a messy. You need to tell the sister, because in case sisters have changed the duty and she doesn't know where exactly it is put, then it becomes a little bit of a problem as such.
The cost factor comes in here with the atosiban.
Cost factor, definitely. That's why people are very finicky in case something goes wrong somewhere, that is the only thing. Otherwise, and second thing is to procure that medicine is little difficult. It is not available everywhere, or not even in in-house hospital chemists. So you need to have a contact number of that particular pharma who is producing this drug, and you need to contact them. He takes at least about 1.5 hours to procure the drug from wherever he or she is, as said, whether it is a daytime or nighttime or whatever it is as such. So just procuring that drug could be little difficult as such, but otherwise once they know how to administer, it's not that much of a problem as such, except that just keeping 2.5 ml in the refrigerator, and when you take a second dose, you're utilizing that. That's all, nothing else. But it's not available in in-house hospital chemists. So you need to have a contact number of that pharma guy who will procure it for you anytime. That is
the same problem we had earlier, of course, with Ritodrin. Everybody said when Ritodrin will come, it's going to be fantastic, super selective, blah, blah, blah. But we found the same issues occurring even more, more than isoxaprine. So these are the things which, sometimes clinical studies and in patient reality, when we are using it, things do differ a bit. Ameya, Pratik, Prof. Dadwal.
Ameya maybe wants to say something.
Yeah.
No, I think I'll let Madam speak first. Then I'll have the last word.
always have the last word.
I'll have a slightly different thing to summarize what both of you have initially conceptualized. Something little different.
All right.
What I was trying to make a...
Yeah. Tell me, Dr. Vatsala.
What I was saying is, like, for the last 25 years, we have been using nifedipine as a tocolytic agent, and we find it very good. So, even like Ritodrin, we don't use... and atosiban also we have used only in research settings. We don't use routinely. So for us, nifedipine has worked very well for the last 25 years.
Thank you.
Okay. We have used nifedipine we are using regularly, but those patients who are high risk, or those ART patients or IVF conception, these are the patients where patients are also very hyper about the whole thing, and they are willing to spend that. These are the patients we've always used atosiban, and we've got good results as such. But only thing, we have a contact number of that person, so he comes and gives it to us, so it's not that much of a problem as such. But otherwise, to procure that drug is a little difficult as such.
Okay, the last word from Ameya.
Yeah, so I want to say that like Professor Krishnendu has said, that the key challenge he foresees in the rampant use of atosiban, the lack of rampant use of atosiban, is the cost effectiveness. We are not finding it affordable enough for the general population, maybe in the public health institutes, even with many of our private patients. Now, whenever an expensive therapeutic modality is introduced, we have something what is called as therapeutic economics, in the sense that this therapeutic modality, albeit it being so expensive, provides such dramatic efficacy that you're ready to pay for that particular therapeutic modality, cost withstanding, because it's going to definitely prevent preterm labor. Unfortunately, with atosiban, whatever studies or whatever Cochrane meta-analysis we have so far, it doesn't say that it reduces the preterm rate so drastically from what we are used to using, or what seems to be a cheaper alternative, namely either the beta 2 agonist or the calcium channel blocker. Clinically, we are more experienced in using it. We consider that these are safer drugs because of the widespread years of usage of this, and we are able to monitor them. Atosiban, no doubt, is safe, but the price that we are paying for its utility, is it going to change the clinical outcomes significantly? Till we are able to prove to ourselves and convince to ourselves and then extrapolate this conviction to our patients, we have not been able to do that, unfortunately, so far. That is what is limiting the use of atosiban. So with any therapeutic modality which is expensive, we need to look at the therapeutic economics of it. In other words, what Amartya Sen has said, and Professor Gupta will agree with me, that whenever you do a big ticket expense, make sure that it is a justifiable expense. It alters the outcome significantly. That's a slightly different take that I have on it. We've used it for a very few patients at the medical college that I am attached to. Okay, we have seen good results, but I must confess to you that those results are not significantly different from what we have seen with the conventional tocolytics that we are using. Till we have a much better protocol, we have a much well-researched study with therapeutic endpoints well defined, side effect parameters well analyzed, I think the routine use is still at the present moment in contemporary practice limited. Like Professor Dalwal said, that it's to a research setting. I think we need, perhaps in the next few years, with it being the new kid on the block, which is available to a greater extent than what it was a few years back, we'll have a better know-how of this drug. Till then, I think we should stick to our conventional tocolytics, that is isosuxprine and nifedipine, depending upon unit protocol. And more importantly, like Dr. Dalvi said, ensure that the baby is delivered with the NICU in the surroundings, because that's going to give you the best outcome.
Dr. Dalvi's finger is up, but I think last word to you then, because then
last word. What he said was correct. So few years from now, we'll have a better result as such, because by then many people would have used it. That's number one. And second thing, so far as cost factors is concerned, they've started with a new study at Sion Hospital where they're using half the dose what we are using it as such, or what they have recommended. But study is still being carried out. So till we have a result from those people as such, whether if you're using half dose, whether it will have a better result or no, we'll have to continue.
In fact, this halving dose was exactly what Ritodrin tablet we had to do. It came in 10 milligrams, we used to give 5 milligrams because the effects were too much. Anyway,
so they are still doing it. So
thank you. Thank you so much, Mr. Dalvi, and we'll move on to the next session. Thank you, Pratik. Thank you, thank you, Nandita, for this opportunity.
Thank you very much, sir. And as the convener, maybe I'll add my 2 cents. Very soon we are going to have a formulation which is going to be introduced in the Indian market. Since everybody is talking about half strength, it is the full strength but at half the price. And very soon we hope to bring you a program regarding that in the later part of this month. So please stay tuned. Thank you so much, Professor Krishnendu Gupta, for joining us and your insightful comments. It's wonderful to have you at our event, sir. Please do join us.
But we keep learning from each other. I always say that, and that's what's best about these things.
One of the side effects of the COVID-19 pandemic. We have a very eminent speaker, Professor Vatsala Dadwal from AIIMS, New Delhi. And for her formal introduction session, can you please share the slide? I would request Professor Purandare to please do the honors.
It gives me great pleasure, honor, privilege to introduce Professor Vatsala Dadwal, who is a professor in chief of the Division of Maternal and Fetal Medicine at the Department of Obstetrics and Gynecology at the esteemed and premier institute of India, namely the All India Institute of Medical Sciences, New Delhi. Her area of interest is fetal medicine, and that's what she's going to be talking to us about today, and mainly diagnostic and therapeutic interventions like intrauterine transfusions, and managing complicated monochorionic twins with lasers for TTS and fetal reduction. Also, she is a well-known figure as far as her clinical acumen and authority on the 11 to 13 week scan and the anomaly scan and the fetal echo. And her passion is to manage high-risk pregnancies. Professor Dhalwal has had major achievements in her professional career, which includes well-renowned research in 130 international and national publications and more than 50 presentations. She has been a principal investigator or a co-principal investigator in 15 international and national clinical studies. As you know, she is a teacher for MBBS and MD students and also for the fellowship program in maternal and fetal medicine at the AIMS. And she's the nodal officer for the PPT-CT program and the executive committee member of the Society of Fetal Medicine 2014-2015, the chairperson of the AOGD Fetal Medicine Subcommittee 2017 to 2019, and the secretary of the AOGD, that is the Association of OBGYNs of Delhi. She has received various awards like the Young Researcher Award, the International Clinical Epidemiology Network, which awarded this, the Rogam Foxy Award in 2008, and the ICMR International Senior Biomedical Scientist Fellowship Award in 2015. So we have a very senior, a very learned, and a very, very accomplished authority from in the field of fetal medicine, talking to us about a very, very specific, highly specialized, but something which we do encounter once in a while during our clinical practice. Over to you, Professor Vatsala.
Thank you, Professor Ramya. Thank you for the introduction. And I thank Dr. Nandita, President of AMOGS, Dr. Pratik Tambe, Dr. Archana Verma for giving me this opportunity to be with you to share my experience. So I'll just share the slides.
Dr. Pratik, Dr. Vatsala wants to be with us for fetal medicine.
Of course, ma'am. You and she will be recurring faculty.
So I've been asked to talk about monitoring for fetal anemia and intrauterine transfusions. So at the outset, I would just like to say that intrauterine transfusion is the cornerstone of treatment for fetal anemia for a variety of causes. And it is the most successful of all in utero fetal therapy till date. And my passion, because we do a lot of intrauterine transfusions for the cases referred to us at AIMS. So I'll talk about fetal anemia. First, I'll discuss about the management of alloimmunized pregnancy, and then I'll go to the other causes of fetal anemia. And what is important that all these cases have to be referred to a center where you have a obstetrician and a fetal medicine specialist so they can be followed and managed to the best. So what is fetal anemia? First, let us understand what is fetal hemoglobin like. So we know that fetal hemoglobin increases as period of gestation increases. So we cannot have a one value cutoff like an adult to say that this is the value below which you will define it as fetal anemia. So there have been various definitions. So people have used hemoglobin deviation, that is the deviation from the mean value. So if the deviation is more than 70 gram per liter, then it is called severe anemia. Similarly, mild and moderate are defined. Or people have expressed hemoglobin as multiple of medians for that gestational age. Or an absolute value of less than 30% of hematocrit has been described as fetal anemia. So hyperops typically develops when the fetal hemoglobin deficit is more than 70 gram per deciliter, or the absolute value is below 5 gram per deciliter. So when we think of fetal anemia, the first thing that comes to our mind is it a case of RH isoimmunization? Although we see non-immune causes of fetal anemia also, but they are much rarer. And these could be, non-immune causes could be congenital infection, but common is parvovirus B19 infection, although it could be other infections also. Inherited anemias like alpha thalassemia, but we don't see that much in our case, in our country scenario. And other causes that we have managed is basically sacrococcygeal teratomas, placental choreangioma, leading to fetal anemia. And there may be some certain other rare fetal disorders which can cause fetal anemia. Then we have fetal-maternal hemorrhage and also complication of monochorionic twins like twin anemia polycythemia syndrome or co-twin demise. So in our context, when we talk of fetal anemia, we are mainly dealing with RH isoimmunized cases. So I would start with that first. Like it is there 2020 and we're still talking about RH isoimmunization. Although we know that prevention is there, anti-D is very effective in preventing RH isoimmunization. But we still see a lot of cases of RH isoimmunized pregnancy. But the good thing is that there is a cure, and with intrauterine transfusions, we are able to give a good success rate. So just to look at the numbers in our institute, so if we see it, like this is the data for the last 15 years. So we were seeing like 54 cases per year in the last decade. But now in the last few years, we're seeing almost 118 cases per year. That is 118 RH isoimmunized women per year we are seeing. So we have done like in the last 15 years, over 1,000 intrauterine transfusions. And problem is the cases have not decreased. The number of IUTs we are doing every year has increased. The only saving grace is that the number of cases referred with hydrops have gone down to half. So this is still a big problem in our country, at least in the northern part of India, and that is a big referral. That makes up the largest number of referral to the fetal medicine unit at AIMS. So with that background telling us the magnitude of the problem, we're starting with red blood cell albuminization. So this occurs when the mother is exposed to paternal antigens which are there on the fetal RBCs, mounts an immune response, and these antibodies can damage the fetal RBCs, leading to anemia, hydrops, or death. Although there are more than 50 antigens on the red blood cell, it is the D antigen, C, KEL, which are mainly responsible for severe fetal anemia. So we also see mainly cases of D antigen, but occasionally we have women who are also like positive, like who have antibodies to C and E antigen. So just a word about the pathophysiology. If a Rh negative woman carries a Rh positive fetus, we know that fetal-maternal hemorrhage is going on throughout pregnancy, and it is maximum at the time of delivery. So once these fetal positive red blood cells can enter the maternal circulation through the placenta, so the initial response mounted by the mother is IgM, and this IgM bodies do not cross the placenta. So the fetus is not really affected in the first pregnancy. It is in the subsequent pregnancy, when the mother is again exposed to the D antigen, she mounts an immune response, which is IgG, and this IgG can cross the placenta and come into the fetal circulation and cause hemolysis of the fetal RBCs. And these antibodies are detected in the maternal circulation by doing the indirect Coombs test. So if the mother is Rh isoimmunized, her indirect Coombs test would be positive. So there is a risk of albuminization to the tune of 16% in ABO-compatible mothers, whereas ABO incompatibility is protective. So overall risk of immunization is almost to the tune of 13% if anti-D is not given. So why does it occur? It's still occurring in our country. Either we are failing to give anti-D, or we don't give the adequate dose, we have missed the prophylactic antenatal dose, or there has been unrecognized fetal-maternal hemorrhage. And what we need to understand is that anti-D will not protect her against developing antibodies to other antigens like C or KEL. So there's certain condition in which you may have large fetal-maternal hemorrhage. So we have to be aware of these conditions. And if possible, we can either determine fetal-maternal hemorrhage by doing these tests, or if not, we can give an additional dose of 300 microgram of anti-D to prevent sensitization. Sometimes even after giving anti-D, failure occurs because the dose may not be adequate because of large fetal-maternal hemorrhage. We have not given it in time, or the patient has very low antibody titers, which could not be picked up by the laboratory. And we thought that she's not isoimmunized, whereas she was already isoimmunized, so anti-D doesn't work. And perhaps maybe monoclonal antibodies are not so effective. So in a study from our institute presented by Dr. Deka et al., we found that half the cases had not received anti-D of the women who were coming with Rh isoimmunization to our clinic. So let's see, if a woman has developed an isoimmunized pregnancy, that is, she is sensitized, what happens in the first pregnancy? So we would know that the mother is albuminized when she has a positive indirect Coombs test. So usually in the first pregnancy, the antibody titers are low, and the chances that she'll have severe fetal anemia or may not develop anemia are very high. If she develops anemia, it is in the later half of the pregnancy. So we usually monitor with indirect Coombs test titers till like sort of every 2 to 4 weeks till 28 weeks and 2 weeks thereof. So we keep monitoring till she reaches a critical titer. Once the critical titer is reached, we know that the baby is at risk of developing severe anemia or hydrops. So we have to monitor for fetal anemia. And what we are using nowadays is non-invasive method, that is middle cerebral artery peak systolic velocity. So how do these women fare? Of the women who have first Rh isoimmunized pregnancy, in a series of 106 pregnancies, they found that 60% did not develop critical titer, so the babies were safe. Of the 40% who developed critical titer, of them, 25% of the babies had severe disease requiring intrauterine transfusion, and 50% of these the babies required some kind of a therapy because of newborn anemia or hyperbilirubinemia. So whenever a woman comes to a pregnancy and she's Rh negative and we do a ICT and point that she is isoimmunized, we check for the titer, whether she has a critical titer or not, whether there has been a previous history of affected pregnancy. If these are no, then we monitor ICT every 4 weeks till 28 weeks and every 2 weeks. If she does not reach the critical titer, we deliver at 37 weeks. If she already has a critical titer, she has a previous affected pregnancy, or during follow-up she reaches a critical titer, then we have to monitor for fetal anemia. Although we may read in literature there is a role of doing paternal zygosity and determining fetal blood group through cell-free DNA in maternal circulation, but unfortunately to most of us this facility is not available. And the reason for doing this is like half of if the father is homozygous, then we know that all the fetuses are going to be Rh positive and the pregnancies would be affected. If the father is heterozygous, then we can do paternal zygosity to see if the father is heterozygous, that we know by the PCR test, then we can do cell-free DNA in the mother circulation. From the cell-free DNA, we can do fetal blood group. And if the fetus is Rh negative, then we don't have to do so much intensive monitoring for fetal anemia, and the mother is also relaxed. So usually the first isoimmunized pregnancy is not so bad, but subsequent alloimmunized pregnancy is not sort of good thing to happen. So when a patient comes to us who has previous affected pregnancy, we always take a history of whether the baby had anemia, required exchange transfusion, had neonatal jaundice. If the baby was hydropic, did she have an intrauterine death? Did she require intrauterine transfusion? Because we know that the affectation is more severe and occurs earlier in subsequent pregnancies, and she would have critical titers. So it is not uncommon for us to see this magnitude of problem that we have 9th, 10th gravidas coming with no or one living issue and losing previous pregnancies to the scourge of Rh isoimmunization. So the main monitoring here is to monitor and diagnose fetal anemia on time so that the baby can be treated with intravascular intrauterine transfusion. So currently the shift has towards non-invasive monitoring of fetal anemia using Doppler for middle cerebral artery, getting the peak systolic velocity. The advantage being there is no fetal loss and there is no risk of exacerbation of hemolysis because we are not doing any invasive testing. Earlier, we used to do amniocentesis. Like for us also, it's 2 decades since we stopped doing amniocentesis. And from 2003 onwards, we're only doing Dopplers. So what was amniocentesis? Basically, in amniocentesis, we're taking out some amount of amniotic fluid, subjecting it to spectrophotometry to see if there is bilirubin present or not. So bilirubin is because of hemolysis, and so it was a indirect test for anemia. It was not exactly telling us if the baby is anemic or not, but we were only saying like baby is anemic because the bilirubin levels are high. So on photospectrometry at 450 nanometer wavelength, if there was a deviation, this was this would correspond to the amount of bilirubin present. So this OD delta value was plotted on Lilly's chart. If it fell in upper part of zone 2 or zone 3, that means the baby is likely to be affected and we would proceed with chordocentesis to confirm for fetal anemia. And if the baby was anemic, give transfusion at the same sitting. But the problem with Lilly's chart or with amniocentesis was that we're doing a lot of procedures in which we thought the baby was anemic, but actually the fetus was not anemic. So unnecessary invasive procedures were carried out. Then ultrasound was also used for diagnosing anemia. So a whole lot of parameters we can see on ultrasound. But what we need to realize is that no parameter is sensitive enough to be used as an independent measure of fetal anemia. In the absence of high drops, we cannot rule out mild or severe disease. So absence of finding on ultrasound does not exclude anemia. So ultrasound is definitely not a good test to look for anemia. So what revolutionized the management of Rh isoimmunized pregnancies or detection of fetal anemia was Doppler of middle cerebral artery and looking at the peak systolic velocity. But whenever we're doing the Doppler, we have to be very careful about the technique if we want to get the correct values. So the section through which the plane of the visualization of the circle of Willis should be axial section of brain, including thalamus and CSP. And usually you put the gate just at the origin of the vessel and keep the angle of inclination as close as possible to 0. Don't try to correct the angle. Try to insonate at 0 degrees with the gate cursor. And we should do it in a time when the fetus is at rest and the mother is not breathing too hard. And then we should not give undue pressure with the probe. So it has to be done in a proper method to give us accurate reading. So why sudden preference for this vessel? There's so many other vessels in the fetal body. Why are we looking only at middle cerebral artery? So in the studies, it was found that in response to fetal anemia, there is increase in fetal blood velocity in various vessels due to increased cardiac output and decreased viscosity. So a number of vessels have been studied, but only middle cerebral artery was found to be most promising and reproducible. And the advantage of using this was that 70% of invasive procedures were avoided, which would have occurred if we were using amniocentesis for detecting fetal anemia. So in the earlier landmark study by Mari et al., they found it to be 100% sensitive. That is, 100% of cases of fetal anemia were picked up, moderate to severe, with only 12% false positive rate. But a recent meta-analysis has shown the sensitivity to be 86% and specificity to be 70%. Although this is the best test for detecting fetal anemia, it cannot diagnose all cases of fetal anemia, nor if it is negative or the MCA-PSV is normal, we can exclude all cases of fetal anemia. But this is the best test that is available for screening for fetal anemia. And we also use ultrasound with it. We also look at the ultrasound parameters to see if there's any ascites or if there is cardiomegaly, which may also be as a marker of fetal anemia. Because sometimes even with severely anemic and hydropic fetuses, we have found that the middle cerebral artery peak systolic velocity is not raised. But we have looked at the ultrasound markers, and considering the previous history of previous babies with high drops or severely affected babies, we have gone ahead and done chordosynthesis for getting a fetal sample for looking at the hemoglobin. So how do we read these values, MCA-PSV? Again, MCA-PSV values are gestation dependent. So they're expressed as multiple of medians. And if the value, any value is more than 1.5, it signifies moderate to severe anemia, and we have to take action. So even if we don't have the chart, we can just understand that for every gestation, if you double the value, if that is the MCA value, then the baby has moderate to severe anemia. So for example, at 24 weeks, it is around 46, so almost double. A double of the gestational age, that number corresponds to 1.5 moms. So this we have already discussed what is fetal anemia. So when should we start doing MCA-PSV and how frequently? So for the first isoimmunized pregnancy, we know that the baby is, there's only 40% chance of the baby getting affected. And if the baby is also affected, the chances of severe anemia is less and occurs later in pregnancy. So we could start monitoring by 20 to 24 weeks, and we could do it once or twice a week. Sorry, once in 1 or 2 weeks. And if the values are rising and coming closer to the 1.5 mom value, then we can do more frequent monitoring. But in previously affected babies, depending on what time the fetus was affected, we know that in this pregnancy, the baby is likely to be affected earlier. So we can start as early as 18 to 20 weeks also. And it is a good value till 35 weeks. And again, depending on the previous history and the present value that we obtained in previously affected pregnancy, we usually do a weekly MCA-PSV, and sometimes we call them even more frequently depending on the value. So if you look at MCA-PSV, this is how we manage. So in a patient who has a ICT titer which is more than critical or a previously affected baby, we start doing MCA-PSV anywhere from 18 to 20 weeks. If the value is more than 1.5 mom and the gestational age is less than 35 weeks, we suspect fetal anemia and plan for cordocentesis and intrauterine transfusion at the same sitting. So we take a sample, and if the baby is anemic, transfuse. If it is less than 1.5 mom, then we keep following with the middle cerebral artery peak systolic velocity. If she has reached more than 35 weeks and the MCA-PSV is showing a normal trend, then we deliver at around 37 to 38 weeks. You usually deliver at 37 weeks, or if the trend is increasing, it is coming closer to 1.5, or she is 35 weeks and more and MCA-PSV is 1.5 or more, then we deliver. We usually do not transfuse beyond 35 weeks because the procedure itself is also risky. So the indications for doing an intratransfusion are when we are very sure that the baby has anemia, and that is if there is evidence of hydrops on ultrasound, or MCA-PSV is more than 1.5 moms. So we have to confirm fetal anemia, we have to take a fetal sample. So we do a cordocentesis, and if the fetal hematocrit is less than 30%, we start transfusion. So we can transfuse as early as 18 weeks to 34 weeks. Definitely intravascular transfusion is very difficult under 20 weeks because the cord is very fine. And beyond 34 weeks, the baby is mature enough to be delivered and it can manage in the nursery. So we usually don't do transfusions after 35 weeks. So how do we access the fetus? So you usually access the vessels in the umbilical cord. The preference is for using umbilical vein, and especially where it is inserted into the placenta, because that part is more stable and easy to puncture. We avoid puncturing the umbilical artery because it is likely to go into spasm, leading to fetal bradycardia and may require emergency cesarean delivery. We do not go near the fetal insertion because of vagal innervation. Again, there is a risk of fetal bradycardia. If we cannot find the umbilical cord, we cannot access the umbilical cord at the placental insertion, we may use free-floating mid-segment of the umbilical cord, but it is usually very difficult to do the procedure because the moment you touch with the needle, it slips and you may have to do multiple attempts to enter. So the other place where you can access the umbilical vein is the intrahepatic portion of the umbilical vein. The advantage here is that because there is no artery nearby, so you cannot inadvertently puncture the artery, so the risk of fetal bradycardia is low. And if there is blood loss from the cord puncture site, it is compensated. It sort of flows into the peritoneal cavity and it is absorbed from there. So the aim is to raise the hematocrit to 45 to 50%. In severely anemic or hydropic fetuses, we don't correct in the same sitting. We usually correct over 2 to 3 transfusions because transfusion would cause a lot of hemodynamic changes and a sick baby will not be able to tolerate that. So there are various formulas by which you can calculate the amount to be transfused, which depends on the fetal hematocrit, the estimated fetal weight, and the donor hematocrit. So this is the Mandelbrot formula, which is pretty complicated. And this is a simple way of calculating. So here it gives you the amount by which you want to increase the hematocrit. If you want to increase the hematocrit by 20%, you multiply with this coefficient and the estimated fetal weight, and that gives you the volume for transfusion. So this is very easy to do. So we have this chart in our OT where we quickly refer to it to calculate the total volume to be transfused. We don't do intraperitoneal transfusions. 100% of our transfusions are intravascular. So before the procedure, we have to have consent. We have to have a good resolution machine, a team available. We should do an ultrasound to see how we are going to reach the cord, where do we plan to give the transfusion. We should have a facility in the OT to do a quick hemoglobin. So we use we use HemoQ in the OT to quickly get the hemoglobin value. And if once the fetus is viable, like beyond 26 weeks, and we give a steroid cover before doing the procedure, so that in case there is a distress, we can do an emergency cesarean section. And our OT is very close to the maternity OT. And also we have to inform our friends in the nursery that we are doing a transfusion in case there is a distress. We may do a cesarean, so they have to keep a bed ready. And we use O negative blood, which is cross-matched with the mother. It should be CMV negative, irradiated, leukodepleted, irradiated to avoid graft versus host reaction, and centrifuge to a hematocrit of almost 70 to 80%, so that with a small volume of transfusion, we can raise the fetal hematocrit. And we use only fresh blood, which is less than 7 days old. So once when we start the procedure, as soon as we usually we always give fetal paralysis before doing the procedure. We use vacuronium in a dose of 0.1 milligram per kg. We either give it intramuscular, or if the cord is placenta is anterior and we're directly entering into the umbilical vein, then we can inject directly into the umbilical vein. Otherwise, if it is a free loop or a posterior cord, then we give vacuronium into the fetal thigh. Once the baby is paralyzed, then only we start the procedure. We enter the needle through the abdominal wall, uterine wall into the cavity, and then with a quick jab, we enter the umbilical vein, take a small amount of blood for doing the hemoglobin and the blood group. Hemoglobin value is immediately available. We calculate the amount to be transfused if the baby is anemic, and transfuse at the rate of 5 to 10 ml per minute. And after the transfusion, we take a small amount of blood to get the hematocrit, because that will help us to decide when to get the next transfusion. And after the procedure, we check the cardiac activity and put the mother on CTG till the fetal movements return and the anesthesia is reactive, because the baby is paralyzed because of muscle relaxant. So for 1 to 2 hours, she may not feel the movements. So this is just a small video which shows that once we have got our blood and everything ready, we give an intramuscular injection into the thigh. So give pancuronium, and once pancuronium is given, we localize the cord. So once the cord is localized, we enter with the needle. I think the video has stopped working. So we enter with the needle through the maternal abdominal wall, placenta, and here into the cord. And once we are in, we take a sample for hematocrit. And as soon as the value is available, we start the transfusion and give the calculated amount of the blood. So here you can see the blood is flowing through the cord. So similarly, if it is a posterior placenta, then we try to see, access the umbilical vein at the cord insertion as far as possible. And sometimes you can have to do it in a free loop also, or we can even do in the intrahepatic portion of the umbilical vein. But for that, the fetal abdomen has to be accessible. And again, here, once the needle is into the umbilical vein, we take a sample and then start the transfusion. So after transfusion, we have to monitor the baby for fetal well-being. Also, we have to decide when to give the next transfusion. And generally, we give the last transfusion around 34 weeks and then deliver at term, unless the procedure is difficult or cord is not accessible properly, then maybe we can decide to deliver preterm also. So MCA-PSP is not really very good in timing the second, third, or the fourth transfusion. So we go by the decline of hemoglobin, which is 0.4, 0.3, 0.2 gram per deciliter after first, second, or third transfusion. And the last transfusion is around 34 to 35 weeks. So how good is the procedure? The survival rates are as high as 90% reported in the literature, and our results are also good. Almost more than 90% survival. Even for hydropic fetuses, the survival rate is almost 90%. But definitely with any invasive procedure, it has its complication. Transient problems like bradycardia and bleeding from the puncture site may occur. But sometimes if the bradycardia doesn't settle down, may lead to emergency cesarean section. Other problems are PPROM or infection. And again, because of the procedure, we again are inciting fetal-maternal hemorrhage, so it makes the disease worse in subsequent pregnancies. So for every time you do a procedure, there is, if you look at the list of complications, there's a 3% risk of complication with every procedure, and there is a 1 to 2% risk of losing the fetus with every complication. And this is our result that we have published, which is comparable to the international literature. Again, if you want to decrease the risk of complications, you have to avoid transamniotic free loop needling, avoid arterial puncture, use fetal paralysis, and Again, procedures before 20 weeks are more likely to have complications. So what is the outcome of these babies? The short-term problem would be hypobilirubinemia requiring phototherapy, exchange transfusion. Because these babies receive multiple transfusion, they have bone marrow separation, so they may require top-up transfusion for the first 3 months of life. Preterm delivery is another problem. And again, problems of prematurity. As far as the neurodevelopmental outcome is concerned, 95% of the babies will have good neurodevelopment outcome. There is some concern as to the long-term outcome in these babies who have received in utero transfusion as to their cardiovascular function, but this data is pretty limited. Then what do we do about cases of very early onset severe anemia? So we do have cases in which patient has had multiple losses, multiple history of hydrops, even occurring as early as 20, 22 weeks. Then what do we do with these patients? Then we have a role of IVIG here. And it has been found that if you give IVIG starting from 12 to 13 weeks in this pregnancy, you may delay the transfusion by as much as 3 weeks. So that is very helpful, and IVIG is helpful in this select group of cases. And we have also done a study in which we have given IVIG with blood transfusion, and we found that the rate of fall of hemoglobin or hematocrit was lower when IVIG was given compared to only blood. So sometimes we have patients who had so many losses and they're pretty fed up. So they may have other options, like they could use a gestational carrier who's not aluminized. We've also had patients who have undergone donor sperm IUI with Rh negative donors because they've had so many losses that they're totally given up. So to conclude, Rh isoimmunization is a preventable disease and anti-D is available. But again, if unfortunately the woman becomes isoimmunized, then fetal anemia is treatable with intrauterine transfusions with good success rate. Again, timely referral is important because these pregnancies need to be monitored for fetal anemia and then subsequently treated. So other rare causes are like congenital infection, parvovirus 19. This can also be treated with intrauterine transfusions. Again, alpha thalassemia major with all the 4 alpha things are all the 4 alpha chains are missing, then the baby may develop hydrops. So in utero transfusion can be given. Again, in cases of placental chorioangioma, we have managed a few cases with IUT in which there was anemia. So I think I'll just stop with this. Thank you. Exceeding time.
Thank you so much, Professor Vatsala. I'd like to ask you one question before we proceed with the actual question and answers. There are a lot of question answers being asked by the attending audience. But first one is from me to you directly that, Madam, we've thoroughly looked at fetal anemia. Are there any fetal intervention strategies for gestational thrombocytopenia which extrapolates into fetal thrombocytopenia?
No, we are not doing any in utero therapy for gestational or ITP, even for idiopathic thrombocytopenic ITP cases also. We are managing with sort of only maternal counts, like treating the mother. There is no role for doing. Earlier, there was some concept of doing a sampling to see the fetal counts and deciding whether the baby is at risk of intracranial hemorrhage, whether you should allow vaginal or cesarean delivery, but now we don't do that.
So we just wait, we deliver the baby as safely as possible and then take it from there.
And the pediatrician will monitor the platelet counts, yes.
Madam, another question that has been asked is by Dr. Pramila Malik from Gurgaon. Dr. Malik has been very active. She's been asking
She is my teacher also. I was a junior assistant when she was a SR. She was with me.
Yes, so she has many questions to ask. So I'm sure that you will address your teacher. She asked why not only packed RBCs in intrauterine transfusion?
We are using packed RBCs only.
Okay. So you don't use whole blood, we use...
No. Packed RBCs packed to the tune of 70 to 80%. When you're giving an adult transfusion, it is packed to a hematocrit of 60 to 65%. We always tell the blood bank double centrifuge to 70 to 80%. So we have to transfuse a small volume to raise the hematocrit.
Okay. So the next question she asks you is a very specific fact-finding question. And she asks you directly, Dr. Vatsala, what is the sensitivity and specificity of MCA PSV at AIMS?
I would say around 90% for first transfusion. We
So-
have our own data, it's almost 89 to 90%.
So it's pretty good, both in
Yes.
terms of sensitivity and specificity.
Yes.
Uh, the next question that she's asked you, it's because you talked about nifedipine being the top priority drug at the AIMS unit. She asks that nifedipine and magnesium sulfate can cause severe hypotension. Do you have any such cases in your experience?
No, we would be careful in giving. So if a patient is on nifedipine, if it like patient is on nifedipine and you need to give magnesium sulfate, you would be careful. But giving a dose or two, it's not really contraindicated. Also, you can give with monitoring.
Okay. She has many more questions. I'll come to you in a moment. First, we'll go to Dr. Raut. So the first question for you is, how often should we test for TNF and NK cells in patients with history of RIF being given lit therapy? Sir, you're muted. Could you unmute, please?
So once we have selected the couple and given the LIT, so before planning pregnancy, what should be done? That's the question, right? So before planning, especially in patients who have high TNF alpha, it is mandatory, or we must do TNF alpha prior to, because it takes almost 4 weeks for the effect of LIT to set in. And once after 4 weeks, the pregnancy can be planned. If that is the time of planning pregnancy, then before that, the TNF alpha levels must be done and confirm that they are back to normal. NK cells, yes, NK cells, we used to repeat all the tests, the cross-match, NK cells and TNF alpha. Then we realized that the outcome did not change with respect to TNF alpha, with respect to NK cells and the cross-match. So we have not been repeating these two tests, but TNF alpha, yes, it has to be should be to normal, and then we plan advise couple to plan pregnancy.
So it's like a prerequisite before they plan a pregnancy.
It should be,
you
yes.
have to have
and
it should have normalized.
Right. So we give LIT and then combine that with antioxidants like pentoxifylline, which additionally helps in correcting the TNF back to normal.
Okay. Sir, one more question. How to separate lymphocytes for lit therapy? Can it be done in any lab, or you require highly sophisticated lab and equipment for this?
No, the separation of lymphocytes is a lab process, and different labs have different procedures to do the separation. So it varies from lab to lab, and the protocols are different because the methods, that is number of times the lymphocyte injections are given, also varies from person from lab to lab. So the procedure is highly sophisticated, and say if you take our example, what we use, our process has been patented, and so usually we have restriction to discussing the detailed process, but the process is different from different lab and it is sophisticated, and that's the crux of the therapy, because that's a lab part, and if proper separation is not done, taking care of the RBC contamination, like just now we heard about RBC sensitization, so all that thing has to be carefully separated. Only then we will get the proper results without complications related to especially red blood cell sensitization. So the process
before I move on to the...
Sorry?
Yeah. No, sir, you want to add something?
No. So therefore, the detailed process I won't be able to tell, but as I said, it varies from lab to lab.
Yeah, it does require some sophistication and some training and some
equipments and yes,
some protocols as far as the lab procedures are concerned as well.
Yes, yes.
Okay. Now, before I proceed to the further questions, this particular webinar, we thought a little differently, and we said, let us take the Janta ka opinion. And so we have the audience poll this time to tell us how good or bad we were, whether we have been rejected or whether we have been accepted in Dr. Raut's terms, okay, or whether we need some transfusion to improve. So this is what the audience had to say. The question that we posed to them was, would you like to subscribe for high risk pregnancy series of webinars? And a staggering number, close to 95%, more than your sensitivity and specificity, Dr. Vatsala, okay, said in the affirmative that they said that they really like the concept, the talk, the speakers, etc., and would like to subscribe. 5% didn't agree with us. There is a 5% of false detection rate and a false positive rate in any test or any intervention we do. So we will make this, we'll try an effort to reduce this 5% even less, but most of the people liked what you said today and would like to hear more such academic events being planned by Pratik, Amogs and Dr. Nandita Parshikar. Pratik, can we move on to just a couple of questions for the third speaker? I think Dr. Hema Divakar is not there, but we'll just, all of us will pool in and give our inputs. Is that okay, Pratik?
Absolutely fine.
Okay. So before I address some of the questions that for Dr. Dalvi's talk, one last question to Dr. Vatsala. Dr. Vatsala, you have a question from one of the eminent doctors of India, Dr. Hema Divakar, past president of Foxy, and she wants to ask you, what are the key points, if you could simplify, when you decide on an intrauterine transfusion? If you could summarize some key points, some take-home messages.
So whenever we see that the baby is likely to be affected with moderate or severe anemia, we would proceed to do a chordocentesis to get the fetal blood for hemoglobin, because that is the diagnostic test for anemia. And then in the same sitting, do the intrauterine transfusion. And how we are monitoring for fetal anemia is middle cerebral artery peak systolic velocity. So if it is more than 1.5 moms, then we know that the baby is moderately or severely affected, then we go ahead to plan for the transfusion. Or if there is evidence of fetal hydrops on ultrasound, then we would do plan for intrauterine transfusion. And we always do a chordocentesis, do the hematocrit or hemoglobin, and in the same sitting transfuse if required.
Okay. My first
Can I add in one something? You're talking about like for alloimmune thrombocytopenia, those cases, we use high dose immunoglobulin and steroid therapy. And with that, like recently we've had 2 cases who have done one. There was no intracranial hemorrhage, any kind of hemorrhage in the fetus. But we don't do any sampling for the fetus.
The concept of sampling, which was earlier hypothesized, has now been given away, and we strongly believe that babies, the baby does better either with the combo therapy that you said, or more importantly with neonatal transfusions, etc., taking a cue from the newborn platelet levels and things like that. Okay. We already addressed the nifedipine hypotension issue, so I'm not going to ask that question again. There's a question which I'll ask Dr. Pratik, because he was one of my colleagues in the preterm group that formulated the preterm guidelines for Foxy. Dr. Pratik, do you see any rationale in using steroid prophylaxis if delivering a 37 weeks normal fetus or a growth restricted fetus?
The last RCOG/NICE guideline which came out on preterm birth, I think they say very clearly that even at 37 weeks, there is a small risk of fetuses being born with what is called as transient tachypnea of newborn. It's not a full-blown respiratory embarrassment which is going to require ICU admission and ventilation, etc., and that entire final common pathway, but may require some observation for 24 to 48 hours. It may be a very small percentage of babies, maybe just 2 or 3%, but even those babies will require monitoring, may cause some amount of emotional distress and turmoil, and especially in the background of an elective cesarean section which is being done. if that baby ends up going to an NICU, even if it is for observation, it is going to leave a lot of questions, a lot of difficult questions for you and your team to answer. So, in the light of that, as you know, the Brits are very safe. They like to sit on the fence, and wherever they have to commit something on paper, they'll be very cautious. So, they have said that even at 37 weeks, maybe one dose of steroid, not the full two doses which we give 12 hours apart or 24 hours apart, even one single dose, if you give, that will protect you on paper as well as that baby from suffering from transient tachypnea of newborn. So, in theory, on paper, you should have the dose given. Now, whether that actually translates into practice, whether those of us who are practicing in institutions are giving it, and those of us who are in private practice where we ourselves make the rules are going to implement it, that is the big question.
So I think the take-home message is that, yeah, Dr. Vatsala.
What I'm saying is, like, there is evidence coming up. There are a lot of population-based studies which are showing that fetus is exposed to steroids at a higher risk of neurocognitive development, autism, and all that. Keeping that in mind, we have to be very careful if you're giving steroids beyond the recommended period. We have to counsel the parents and tell them the benefits and the risks. Because we would not usually give beyond 34 weeks. 34 to 36 is also like, I don't remember the name of the study, but that showed that between 34 to 36 weeks, it may reduce composite morbidity, but that was also in terms of transient tachypnea. They didn't take actual RDS into account.
Yeah, I think that's a very good point. And the take-home message for the audience should be, yes, after 34 weeks, it would be using steroids would be a highly judicious decision. Generally, from the scientific viewpoint, the lungs have matured well enough for the baby to survive and not require steroids. However, keeping in mind the possibility of TTN, where suspicion or a probable chance of TTN is anticipated, in such situations, taking in mind and counseling the patient appropriately that this is an intervention keeping in mind aimed at benefit to the baby, it could be discussed. I don't think in our population or any recommendation we are seeing that routine use should be used at term of steroids. The Brits have probably said it, but we have not yet said it in any form of either government guideline or any professional association guideline so far. We'll move on to one more question. And Dr. Vatsala, again, it's from your teacher. She wants to ask you, is alpha thalassemia major compatible with life?
Alpha thalassemia major is not compatible with life because the fetus is not producing any of the alpha chains. But in utero transfusion can make the baby survive. After delivery, you could think of bone marrow transplant or something like that. And we have not seen any case of alpha thalassemia major till now.
Apparently, it's the most challenging.
Very rare.
Yeah, very rare and extremely challenging course, both in utero as well as ex utero as well, because the only survival that they say is with a bone marrow transplant. And how early are you going to do a bone marrow transplant for this barely newborn baby? So overall, it's a very grim situation, unfortunately, if one is faced with such a situation. Dr. Pratik, one last question to you before probably we can end today's questionnaires. And then I'll take an opinion from Dr. Vatsala with respect to her unit policy. And that is, Pratik, in your practice, do you screen the mother routinely for any infection in pregnancy, specifically for UTI, high vaginal culture? Do you use CBC as a marker? And which are the patients you usually treat if any of these screen tests come positive? So I'll just repeat, do you screen? Who do you screen? What tests do you employ? And what therapy do you offer there?
So this is a rarely used intervention in general obstetric practice, and I'm making this rather cynical comment that at 35, 36 weeks, all of us should ideally be doing a per speculum examination of our pregnant mothers. If we find that there is a vaginal discharge, these are the patients who will most likely benefit from a proper high vaginal swab and a bacterial culture and an empirical treatment, whether it's a fungal infection or it's a bacterial vaginosis. These are the patients who need to be definitely treated. Whether we should adopt a universal policy of screening everybody, I think we have not yet reached that stage in India because it would not be cost effective. Universal screening for thyroid, yes. For diabetes, yes. But universal screening for vaginal infections, cervicovaginal infections, at least in the shape of a simple per speculum examination, I think all of us should be able to do. That is sometimes sadly lacking when you have 500 patients coming in the space of 2 or 3 hours in a major public hospital. It's very difficult to allocate resources and do that. But if you spend that time, I think you will be richly rewarded because a lot of these patients will go on to have complications later on, which you can identify, treat, and prevent.
Okay. So the take-home message that you're saying is that universal screening doesn't seem to be a practical solution in present practice, especially with the overburdened public sector. I'd like to ask Dr. Vatsala, who is from a very large public hospital. Dr. Vatsala, so then if not universal screening, then selective screening would be for which patients for vaginal infection? I mean for infection in pregnancy.
So like all the patients who are symptomatic, we are examining. Patients with previous history of preterm births in early part of pregnancy, you can do a speculum examination, and if they have bacterial vaginosis or something, you can treat. But generally, there is no recommendation for screening all pregnant women for for genital tract infections as a measure to prevent preterm birth. So we don't routinely screen everyone. Usually the symptomatic patients we would do. But for asymptomatic bacteriuria, we would screen for all women around 16 to 20 weeks. And for some infections like hepatitis B, hepatitis C in high risk, otherwise HIV, and VDRL, we're screening all patients at first visit.
So it should be a selected screening, it should be a targeted screening. So the three important subset of patients would be: one, obviously, who are symptomatic; number two, who have had a history of infection or those with previous preterm birth; and number three, who are likely or probable to have an infection, some kind of an immunocompromised status, diabetes, poor personal hygiene, have had an episode in the past of an infection which has been treated in the recent past. These would be patients who you would selectively screen and therefore catch the infection early and arrest the positive factor leading to the preterm labor by giving appropriate antibiotic or antimicrobial therapy. I think Dr. Malik did ask this question as well, that whether do you screen for preterm, and we've addressed that. I think most of the questions seem to be covered. If there's anything else that you would like to add.
I'd just like to invite our speakers to give one final closing remark before we present the official vote of thanks. I think Dr. Archana Verma, Professor Krishnendu Gupta, and Dr. Rajendra Singh Pardeshi have left. Dr. Sujata Dalvi has also left for other events. So we have Professor Mohan Raut and Dr. Vatsala Dadwal. Please give us your final closing comments, and then we'll have the vote of thanks.
I think in patients with recurrent pregnancy loss or recurrent implantation failure, especially when we find no cause, it is always worthwhile looking for alloimmune factor. Though, as I mentioned, the tests which are used are not 100%, but yes, they do help us to select couples who can be given immunomodulatory treatment. And again, it is worthwhile using immunomodulation in these patients to so that the pregnancy is successful. So always investigate for alloimmune problem, give immunomodulation before pregnancy, and during pregnancy use immunomodulatory medications, as I said about immunoglobulin or intralipids, which help to maintain the immunomodulatory effect during pregnancy. And I'm sure not all, but as again I mentioned, that there is a subgroup of patients who will definitely be benefited, and with more time, with more better investigations like Treg cells, we will be able to separate or categorize this subgroup more specifically, and then use immunomodulation only for that group, which will definitely then show good results with respect to the effect of immunomodulation in these cases.
Professor Vatsala?
What I would like to say, all pregnant women in their first antenatal visit should have a blood group and RH typing. as a routine test. If she is negative, do the husband's blood group. If he is negative, still do an ICT. If the husband is positive, do the ICT. If she is not ICU-immunized, give her antenatal anti-D at 28 weeks. And after delivery, depending on the baby's blood group, if the baby is RH positive, give anti-D. If the baby is RH negative, you don't need to give anti-D. If the woman is ICU immunized, the ICT titer is positive. Once it reaches a critical titer, please refer her to a unit where she can be monitored for fetal anemia and given an intrauterine transfusion if required.
Okay,
So,
Pratik, just one last comment before I hand it over to you. I
Yes,
think
please.
what our three speakers have said today through their talks is that we were always told, and I think everybody agrees with me, that the key to a successful pregnancy, especially in the presence of a challenging situation, may be a pregnancy loss, maybe an RH sensitized pregnancy, or maybe a preterm labor or a threatened preterm labor, is to not forget those three important words, that is TLC, tender loving care. It may be that immunotherapy is a type of tender loving care in Dr. Raut's eyes and beliefs. It could be putting the needle to give blood to restore the hypoxia, and to ensure adequate oxygenation with Professor Dalwal's needle, which goes through carrying the blood there. At the end of the day, or Dr. Sujata Dalvi's tocolytic approach with steroids and antibiotics, ensuring that the baby goes in a well-equipped NICU. At the end of the day, we have to ensure that the patient gets our commitment and gets the belief that all that we are doing for her is for hers and her baby's benefit, and therefore the importance of tender loving care, especially in these challenged pregnancies. That's all I had to say, Pratik. Thank you for the opportunity. It's been fantastic. I think the level of academics that we've shared this afternoon is extremely noteworthy and of the greatest standard.
Thank you so much, my dear friend Dr. Amay Purandare. To present the official vote of thanks, I must start with acknowledging and thanking my president, Dr. Nandita Palchetkar, secretary, Dr. Arun Nayak, my zonal coordinator, Dr. Kedar Gandla, four fantastic chairpersons, our vice president of AMOX, Dr. Rajendra Singh Pardeshi, regrettably couldn't join us today. Professor Krishnendu Gupta, his comments were extremely insightful. Dr. Archana Verma is always a, I would say she is like an entire compressed ball of energy. Wherever she goes, she radiates so much positivity and energy that you can't resist being affected and infected by it. Dr. Amay Purandare for his excellent and insightful comments, his brilliant and sharp criticism and thought-provoking remarks on every speaker and every topic. And thank you also for conducting the Q&A session. We had three amazing speakers. Dr. Mohan Raut regrettably could not join us earlier, but I'm very happy that today we could find a date in his calendar and we could have him on the AMOX platform to share his wonderful work. He's one of the unique personalities in India doing pioneering work in this field of immunotherapy. We had wanted to have him for a very long time, and thank you so much for joining us today, sir. Professor Dadwal, I think your talk was simply mind blowing, and it is going to take us some time to fully assimilate everything that you taught us in that half an hour. Your decades of expert research and knowledge really shone through in your talk. There is no amount of praise that will be sufficient for Dr. Sujata Dalvi for her brilliant rendition on preterm labor. And of course, at the end, I have to express my gratitude to Bharat Serums and Vaccines, our academic partners, the Feminora division, for partnering with us in this unique initiative through the Bridging Bharat series of events which we are doing. To Science Integra, Session, Subbu, Shrimon, Meenal, all of you do fantastic work. Thank you so much for that wonderful audience feedback that came as a much needed shot in the arm when all of us were questioning whether it is worthwhile continuing doing webinars when there are at least half a dozen other events on the same day for the audience to choose. We have nearly 600 participants today at today's event, and you can see 95% of them gave us a positive feedback. Hats off to you, Science Integra. And I think without in any way exaggerating, I would say that it is all thanks to your hard work as the backbone and to all the eminent faculty who participate in our programs. Thank you so much. Goodbye. God bless. We'll see all of you very soon.
Thank you.
Thank you. It was a very interesting and sort of stimulating webinar. Thank you.
Thank you very much. Thank you, Dr. Ameya, Dr. Pratik, and Dr. Jadwal.
Thank you.